Dr. Bharti?
Kumar.
Okay, we can start now. Unmute yourself.
Yes,
Unmute yourself.
Yes. And first, I'm going to show a small introductory video we have made of our activities. There are a lot of ROP agents. At least people are doing lasers. Dr. Bibhuti, Bhushan, other people made a small introductory video. Introductory video. So, welcome to this interdisciplinary retinopathy of prematurity webinar. I am Dr. Bharti Kashyap, Chairman Scientific Committee, Jharkhand Ophthalmological Society. And this webinar is an academic initiative by Jharkhand Ophthalmological Society, along with Ranchi, Dhanbad and Jamshedpur Ophthalmological Societies, with esteemed panelists from Jharkhand, JHOS, FOXI and IAP chapters. We all know ROP is a blinding condition if not taken care of in the beginning itself. So awareness is very important, not only for ophthalmologists and neonatologists, but also for obstetricians. We are going to discuss today in the light of what is going in our country, as the situation is different in the developed countries, and it has a serious medico-legal impact also. Today's webinar will be covered by legendary obstetrician of our state, Dr. Shobha Chakraborty ma'am, Paediatrician, Dr. Rajesh Kumar, Chief of Eastern India's largest private children's hospital, Rani Children's Hospital, with largest NICU, and ophthalmologist, Dr. Bibbhuti Kashyap, and AIMS ROP trained FRCS vitreoretina surgeon and head of vitreoretina department, Kashyap Memorial Eye Hospital, Ranchi. Despite there being a massive advancement in neonatal care, not only in big cities, but also in the smaller towns, ROP remains the leading and most preventable cause of infant blindness. One of the 5 blind child in India is because of the retinal causes. And approximately 80% of this is preventable and comes from a single disease, that is retinopathy of prematurity. And there is gross underreporting of ROP in our country. Why 2 decades back there was very less cases of ROP? Because neonatal care was not that improved. Nowadays, neonatal care has improved greatly, and babies are surviving to an age where ROP screening is needed. So the severity has decreased of ROP, but the incidence of 41.5% has not decreased, apart from low birth rate and exposure to uncontrolled oxygen delivery in first 6 hours of birth. There are so many other factors and management about which we are going to learn today from the masters of this field. So now I welcome all the legendary speaker, Dr. Shobha Madam, Dr. Rajesh Kumar, and the young dynamic Bibbhuti Kashyap, as well as our esteemed panelists from JHOS, FOXI and IIP chapter. So now I will invite our esteemed president, Dr. Halimuddin. And before that, I want to introduce you. So there will be a formal introduction of everyone. We are 4 coordinators. Our past president and management committee member, Dr. Bibbhuti Kashyap, is with us as a coordinator. Dr. Bibhuti Bhushan, our secretary, my team, is also with us as a coordinator. Dr. Malay and Dr. Rekha is with us as a coordinator. And there will be a formal introduction one by one by each one of us for the entire level, the entire panelists and speakers. So first, I invite our president, Dr. Halimuddin, for the welcome address. Halimuddin, sir, please, over to you.
Yeah. Good evening, everybody. I, Dr. Halimuddin, having my
privilege and pleasure on behalf of Jharkhand Ophthalmological Society as its president to welcome you all at this virtual webinar of retinopathy of prematurity. And we are delighted and honored to have with us speakers like Madam Shobha Chakraborty, Senior Paediatrician Dr. Rajesh Kumar, and the young and dynamic vitreoretinal surgeon Bibbhuti Kashyap. And I welcome my dynamic panelist coordinators who are participating and share in this webinar. My heartfelt thanks to the organizing team from Microvision, Bangalore. Thank you very much.
Now I invite Secretary Dr. Bibhuti Bhushan, the JHOS Secretary Dr. Bibhuti Bhushan, to introduce the esteemed speakers and the Jharkhand Ophthalmological Society's coordinators. Over to Dr. Bibhuti Bhushan. Please unmute yourself. Dr. Bibhuti Bhushan. अच्छा ठीक है, मेरे को म्यूट करो.
Can you hear me? Hello?
Yes,
Can
sir.
you hear me?
Clear. Yes,
Yeah.
sir. Yes, sir.
Okay. Okay. We are privileged to have Dr. Shobha Chakraborty as a expert speaker in our webinar. She passed MBBS in 1965 with 4 gold medals in physiology, pathology, surgery, and ops and gynae.
स्लाइड नहीं दिख रहा है.
Slide share किए हुए हैं?
स्लाइड तो नहीं दिख रहा है.
नहीं सर, स्लाइड शेयर नहीं हुआ है सर.
Okay. I'll just
वापस एक बार
this
शेयर
slide.
कर लीजिए सर.
Right.
क्या शेयर कर ले? शेयर कर ले.
अब आ रहा है?
नहीं.
सर नहीं, ये शोभा मैडम का स्लाइड आ रहा है.
मैडम का स्लाइड चाहिए.
शोभा मैडम का ही
स्लाइड नहीं, शोभा मैडम का इंट्रोडक्शन स्लाइड.
शोभा मैडम का प्रेजेंटेशन वाला अभी नहीं चलना है.
नहीं, प्रेजेंटेशन वाला नहीं चलना है.
Because she is sharing actually, इसीलिए मेरा नहीं.
मैडम उसको हटाइए. निवेदिता हटाओ वो स्लाइड. हम लोग मैडम का इंट्रोडक्टरी स्लाइड लगाएंगे. मैडम का इंट्रोडक्टरी स्लाइड लगाना है अभी. विभूति भूषण लगाओ मैडम का इंट्रोडक्टरी.
I don't think that is needed.
अब आ रहा है?
नहीं आ रहा है.
नहीं है सर, नहीं आ रहा है सर.
क्या पता क्या हो रहा है आज.
विभूति सर शेयर स्क्रीन में जाइए. हाँ, अभी आ रहा है सर, अभी आ रहा है.
अब आ रहा है?
Yes.
Now it is coming.
इसके बाद सर है, सर के बाद मैडम.
अब आ रहा है फुल स्क्रीन? ठीक है. Okay. Now we are really privileged to have Dr. Shobha amongst us as a guest speaker, as an expert speaker. She passed her MBBS in 1965 with 4 gold medals in physiology, pathology, surgery, and ops and gynae. She passed MS in 1971 and did her residency and registrarship from PMCH. She joined RMCH way back in 1974 as an assistant professor and became professor and head of the department of ops and gynae in 1984. For 14 long years, she headed the department and groomed the department. She retired in 1998. A great academician and a teacher par excellence that everybody will vouch with me. She had numerous papers and presentations in various national and international conferences. She was the past president of ROGS and she is a patron of Ranchi Ops and Gynae Society. We are really privileged to have you, ma'am, on this show today in the evening, and we are looking forward to your presentation. Next, we have the renowned pediatrician, Dr. Rajesh Kumar, who did his MBBS from JIPMER, MD and DM Neonatology from PGI Chandigarh.
ऐशो इधर आओ.
Hello. Am I audible?
Yeah, please continue.
Yeah. He did his MD and DM neonatology from PGI Chandigarh. He is the director and chief neonatologist of Rani Children Hospital, Ranchi, which is a state-of-the-art tertiary neonatal care center catering not only to Jharkhand but the whole eastern region. We welcome you, Dr. Rajesh, and we are looking forward to your presentation. And we have a very young and dynamic Dr. Bibbhuti Kashyap, who did his MD from AIMS, New Delhi, and has been trained in the subspecialty of retina, uvea, ROP, cataract, and refractive surgery. He stands out as one of the most, not one of the, as the most qualified ophthalmologist of our state, with over 12 professional degrees to his name, including FRCS. He has been trained in ocular oncology by the stalwart of medical retina, Professor Giovanni, in Milan, Italy. With thousands of anterior and posterior segment surgeries under his belt and over 1,000 ROP treatments, he is currently the head of the retina services at Kashyap Memorial Eye Hospital, Ranchi. An excellent speaker. We really like to hear you, Bibhuti, and we are looking forward to your talk also. Should I introduce the coordinators also?
Yes, yes.
Yeah, we have our past president, Dr. BP Kashyap, as the chief coordinator of this session. He is the founder director of NABH accredited Kashyap Memorial Eye Hospital Private Limited, Ranchi. He did his Masters of Surgery in 1989, and he is a trained retina fellow from Retina Foundation, Ahmedabad. He is the pioneer of phaco cataract surgery in the Eastern India. He has participated in many cataract and glaucoma live surgery workshops all over the country and performed live surgeries. He started cornea grafting in Bihar and Jharkhand from locally retrieved cornea in the year 1995. He founded Kashyap Memorial Eye Bank, the first active eye bank of Bihar and Jharkhand. He is the past president of JHOS and managing committee member of All India Ophthalmological Society, representing Jharkhand Ophthalmological Society. Then we have our president, Dr. Halimuddin, who will also be there as a coordinator. He performs anterior segment surgeries, including simple and complicated cataract surgery via phacoemulsification of SICS techniques, and he is a very renowned ophthalmologist in the city of Ranchi. Dr. Halimuddin is also highly experienced in handling glaucoma and oculoplasty. Then we have our dynamic chairman, scientific committee, Dr. Bharti Kashyap, who will be also there as a coordinator. She is the first woman ophthalmologist of India to get the Nari Shakti Puraskar by Honorable President of India. She is the founder director of Kashyap Memorial Eye Hospital. She is also the medical director of Kashyap Memorial Eye Bank. With her husband, Dr. BP Kashyap, she had the privilege of first cornea grafting of Jharkhand and Bihar from first locally retrieved cornea in 1995. She is the chairperson of Scientific Committee of JHOS. She is Secretary Women Ophthalmological Society of Jharkhand chapter. She is also the Secretary of International Society of Manual Small Incision Cataract Surgeons Jharkhand chapter. She is Secretary, Ranchi Ophthalmic Forum, and the chairperson of Women Doctors Wing, IMA, Jharkhand. Then we have Dr. Malay Dwivedi, who is Secretary of Jamshedpur Ophthalmological Society. He did his MS Ophthalmology, and he is a Pediatric Ophthalmology Fellow from the renowned Arvind Eye Hospital, Madurai. He is a consultant pediatric ophthalmologist from MG Eye Foundation, Jamshedpur. Then we have a very dynamic Dr. Rekha Singh, who is a secretary of Dhanbad Ophthalmic Forum. She has done her MS from BHU, Varanasi, and she is a senior consultant in Department of Ophthalmology, Tata Central Hospital, Dhanbad. Thank you very much. And that was the brief introduction of the guest speakers and the panelists. Now over to Dr.
Now over to Dr. BP Kashyap to introduce our dynamic secretary, Dr. Bibhuti Bhushan, and the JHOS panelists. We have a few panelists from Jharkhand Ophthalmological Society. So now over to Dr. BP Kashyap to introduce our secretary and the panelists. JHOS panelists. Over to Dr. Kashyap.
Good evening, everybody. In a galaxy of very intellectuals, the opticians and the pediatricians, and galaxy of intelligent young ophthalmologists of Jharkhand. And I must thank Dr. Bharti Kashyap to have given me the opportunity to introduce our people from Jharkhand. So first of all, let me introduce you our young and dynamic Dr. Bibhuti Bhushan, who is a Sankar Netralaya trained retina person. He has done his MS from Regional Institute of Ophthalmology, AMU, Aligarh, and he has a very keen interest in medical retina, and he has quite an expertise in ROP. So you can rest assured that you will get a lot of questions from Dr. Bibhuti also. He is basically based in Jamshedpur. He is at present the Secretary of Jharkhand Ophthalmological Society. You can see this young man, Dr. Sushil Bajoria. He's popularly known as General Bajoria. He's our college mate from Armed Forces Medical College, Pune. He's at present heading the Department of Ophthalmology at Tata Main Hospital. Dr. Sujay Samanta, he has highlighted the area in Jharkhand, that is Hazaribagh. Now he is known as a king of Hazaribagh. He is an eminent, very eminent cataract and glaucoma surgeon from Hazaribagh. He had been the past secretary of Jharkhand Ophthalmological Society. He has a very keen interest in retina and ROP. Dr. Vandana Prasad is one of the power women of Jharkhand as an eye specialist. She heads the Shri Jagannath Hospital Research Center at Ranchi. She basically practices anterior segment, the pediatric ophthalmology, medical retina, and she also has a very keen interest in squint also. She has been in different posts of Jharkhand and even the All India Ophthalmological Society posts, like a management committee member, and she's also probably had been the member of Niti Aayog, a very important and powerful lady from Jharkhand from our society. Dr. S.K. Mitra is a lovely man. He is from Jamshedpur. He is an anterior segment surgeon. His videos of heart cataract surgery is very, very popular. He is the person who, you can see him in a lot of workshops in different places. Most of the time we have done surgeries together. He is basically from Jamshedpur. You will love his speech. You love his questions. And he also has a very keen interest in retinopathy of prematurity. The other person, Dr. Rajan, hats off you, Dr. Rajan. In a very short span of time, you have earned a quite good name. You are based in Jamshedpur, and he is expert in phaco emulsifications, and he's heading one of the. Dr. Neeraj is a very surgeon, vitreoretinal surgeon. He has done a lot of ROP work in Ranchi and around places. He is attached to a lot of hospitals for the ROP, and he had worked with us for a very long time. And he is a very humble guy. And the most important part is he is the most eligible bachelor for the marriage. If you have any girl for him, please go ahead. And Dr. Seema Patwari, she has been trained for the medical retina. She heads the Jharkhand Diabetic and Eye Center. She has done her fellowship from Chennai. Dr. Rahul Prasad, a self-made person, he has grown from I have seen him growing. Now he is associate professor in RIO RIMS. He is heading the cataract and retina services. He has a very keen interest in retina. He has been trained for the retina. Now he is looking after the ROP, and you can expect very logical and very interesting questions to Rahul. So thank you very much, everybody.
Okay, thank you, Dr. Kashyap, for such a nice introduction of all. So, am I audible, Dr. Bibhuti?
Yes, madam, you are audible.
Okay.
Yes, you are audible.
So now I am going to introduce the esteemed panelists from FOCSI Jharkhand chapter and IAP chapter. So first I am starting from FOCSI. Maya madam. So Dr. Maya Verma is our esteemed panelist from FOCSI. She is president of ROCS, She is ex-professor Ops and Gynae, RIMS Ranchi. She is keenly concerned in social welfare work with different NGOs, currently practicing as a senior consultant Ops and Gynae at Ranchi. Welcome, madam. Dr. Geeta Sinha Manti, she is the dynamic secretary of Ranchi Obstetric and Gynaecological Society. And she is the one person behind this webinar's connection with all Jharkhand folksy. So she told me that you should unite the entire Jharkhand chapter. So welcome, Dr. Geeta Sinha Manki, madam. Dr. Banita Sahai, she is MS from RIMS, presently posted in MGM Medical College. She is President Ops and Gynae Jamshedpur chapter. She has published many research papers in national and international journals. She is awarded as Best Doctor, INEX, Dainik Jagran, and Hindustan. Dr. Rajni Bagai, people say that Vardi daughter, son of Vardi father. I will say Vardi wife or Vardi husband. Her husband is also a great cardiac surgeon, and she's a great obstetric and gynae person. She's MD from JIPMER Pondicherry, and she is the head of the department OBGY, Tata Motor Hospital, Jamshedpur. She has a special interest in laparoscopic gynae surgery, pelvic floor surgery, and high-risk pregnancy. Welcome, madam. Rajni Bagai, madam is here, na? Bibhuti?
Yes, she is here.
Okay. So, Dr. Bibhuti Banerjee, she is MS and DNB, and she's also a member of FOXI. She's Vice President, Jharkhand Women Wing. She is my batchmate above all, and she does surgery. She has done Master of Surgery, so she does both the surgical practices and OBGY practice. So Dr. Santavana Sharan is the obstetrician and gynecologist. She is medical officer in charge, Ramgarh Kent, and she's a consultant gynecologist, mother and child healthcare, Ramgarh. Recently, she has become the secretary of Pink Health Mission of IMA. It's a very important chapter of National IMA, and I really congratulate Santavana that she has achieved this milestone. Congratulations, Santavana. Dr. Archana Kumari is Associate Professor, Department of OBGY, RIMS, Ranchi. She is Secretary, ISO PAB, Ranchi chapter. She is Secretary, IFS Jharkhand chapter. Welcome, Dr. Archana. Dr. Kavita Priya is Deputy CMO, Central Hospital, Dhanbad. She is President, Dhanbad OBGY chapter. And she's organizing, she is a speaker at AAGS BJ conferences at Bokaro and Darbhanga. And she is organizing, she has organized so many conferences, and she's a very dynamic young gynecologist. So Dr. Nibedita Chakraborty is the worthy daughter. She is a daughter of Dr. Shobha Chakraborty and very accomplished gynecologist. She completed MS OBGY in 2007, and she is a diploma in gynecological endoscopy, diploma in oncology. She has done MS and diploma in gynecological endoscopy also. Dr. Neetu Sahai, whether she is present or not, Dr. Neetu Sahai has joined.
You go ahead and introduce her.
Okay, Dr. Kiran Trivedi. She is a very young, enthusiastic gynecologist from Ranchi. She has done MD and she is ex-joint secretary, Ranchi FOXI chapter. And she is at the moment treasurer. She is life member, IMA, FOXI, ISO, PAB, IFS. She has presented papers in national and international conferences, and she has publications also in national and international journals.
Dr.
Welcome.
Neetu Sahai is also there.
Okay, Dr. Neetu Sahai is there. Dr. Neetu Sahai is director of New Shri Clinic, Dhanbad. She is trained in gynecological laparoscopic surgeries. She is secretary, Dhanbad Society of Obstetric and Gynecology. She is secretary, IMA Female Wing, Dhanbad. She is bestowed by Nari Samman by Sahitya Academy. She is the Best Doctor Award by Dainik Jagran. And she's organized many awareness programs of cervical cancer and breast cancer. And she is a faculty in AICOG 2020. So now I'm going to introduce the esteemed panelists from IAP, Pediatrics chapter. So please, Pediatrics ka laga dijiye. I will introduce those only who are participating and who are present at the moment in the webinar. So Dr. O.P. Mansaria is present here. He is the chairman and chief pediatrician for Ranchi Group of Hospitals in Jharkhand. He is the first certified neonatologist and pediatric intensivist of Jharkhand. Over 40 years of treating experience in ICUs. Welcome, sir. Dr. Smriti Nash is and she's past president IAP Jharkhand. She's head of the Department of Pediatrics and NICU, working as chief consultant at Tata Motors Hospital since last 29 years. Welcome, ma'am. Dr. Prakash, he's there. Dr. Bibhuti Bhushan. Dr. Prakash.
He is there. You go
Doctor,
ahead.
who is the director, Shaurya Children's Hospital, Ranchi. Dr. Sailesh is very young. He's young dynamic pediatrician since 20 years. He's attached to Rani Children, Ranchi. Dr. Rajesh Sharan is very enthusiastic. He's senior consultant, Department of Pediatrics, Tata Motors Hospital, Jamshedpur. He's associate editor, Journal of Neonatology. Welcome, Dr. Rajiv. Dr. Rakesh is the secretary of Ranchi Pediatric Chapter, and he's from PGI Chandigarh, and he's director consultant pediatrician and neonatologist at Siddharth Children's Hospital, Hinu, Ranchi. Dr. Shanti Bhushan is the consultant pediatrician and neonatologist at Patliputra Nursing Home. He is done also MBBS from Jipmar and MD Pediatrics from Maulana Azad Medical College, New Delhi, and he is senior residency from Safdarjung. He has more than 14 years of experience in the field of neonatology and pediatrics. Dr. Abhishek Ranjan is AIMS guy. He has done from AIMS Delhi. He's a pediatrics and he's associate professor, Department of Pediatric, RIMS. He is Dr. Rajesh Kumar is MD Pediatrics, Director, Balpan Children's Hospital, Ranchi. Dr. Abhishek Shukla has done MBBS, DCH, ECFMG, and MIAP USA. He is the consultant pediatrics and neonatologist, Asian Jalan Super Speciality Hospital, Dhanbad. More than 12 years of experience of working both in India and abroad. He is also a very young, dynamic chap. Dr. Raj Sinha, he is MBBS, DNB2 pediatrics. He is practicing as a pediatrician since last 16 years in Archana Clinic. Ramgarh has a NICU setup at MCSC Hospital also. Welcome, Dr. Rajesh. Dr. Priya Amitabh is a young consultant from pediatrics, Tata Motor Hospital, Jamshedpur. Joint Secretary, IAP Jamshedpur branch. Welcome, Dr. Priya. Dr. Vikas Kumar is another young dynamic personality from Hazaribagh. He is MD Pediatrics, consultant pediatrician and neonatologist come director, Chhidis Hospital and Research Center, Hazaribagh. And he is worthy son of worthy father. His dad was a very renowned ophthalmologist, Dr. M. Singh from Hazaribagh. So we are done with the introduction part. So now I over to Vibhuti Bhushan. Please invite Shobha madam for her presentation.
Yeah, I request Dr. Shobha Chakraborty to kindly share her screen and start with the presentation.
Madam, please share your screen.
Share.
Good evening to everybody. Dr. Bharti, I thank you very much for inviting me. My best wishes to everybody present here. You know that the retinopathy of prematurity is a very important cause of blindness throughout the world and India also, our part also. So the retinopathy should be treated. And before we treat retinopathy, we know that it is a retinopathy of prematurity. Prematurity is the background of retinopathy. So as an obstetrician, our aim will be to prevent retinopathy, prevent prematurity and treat prematurity if there is.
Ma'am, you are not audible.
Nivedita ma'am.
Yeah, 1 second, ma'am, 1 second.
Now, blindness due to retinopathy is preventable. You all know that. And cornerstone of to stop and to prevent blindness is the prevention of prematurity. Now, why ROP?
थोड़ा मोबाइल लेके थोड़ा डिस्टेंस बना देंगे तो वॉइस क्लियर आएगी. ओके.
सब लोग म्यूट करो खुद को, मैडम बोल रही है.
ROP, why important? India shares 20% of all childhood by blindness. Out of 100 preterm infants, 20 to 40 develop ROP. out of which 3 to 7 becomes ultimately blind. The incidence of ROP is increasing due to better survival of low birth weight and preterm babies availing modern neonatal facilities and care. So, with preventing prematurity, with early detection and timely intervention, blindness is prevented. Now, what is prematurity? WHO defines prematurity as babies born before 37 weeks of gestation. Every year, 15 million babies are born prematurely worldwide, and 1 million children die each year due to complications of preterm. India, the biggest contributor of world prematurity burden, of course, besides Africa. In India, out of 27 million babies from every year, 3.6 million babies are premature. Now, India has the largest number of preterm births. And this preterm, we divide into early preterm and late preterm. The early preterm, again, extremely preterm, less than 28 weeks, and very preterm, 28 to 34 weeks. Now, before we start treating prevent the prematurity, we must know the causes of preterm birth. The causes, important causes are spontaneous unexplained preterm labor, preterm premature rupture of membrane, iatrogenic maternal indications, preeclampsia, eclampsia, etc. Fetal indications, and most important fetal indication is intrauterine fetal growth restriction. And then is the infection and inflammation. And last several years, this infection and inflammation is becoming the topic of discussion in our subject. The risk factor. What are the risk factors of prematurity? Risk factors are previous repeated preterm labor, mid-trimester abortion, bleeding and early weeks of pregnancy, multiple pregnancy, and cervical incompetence, uterine anomalies, a preterm premature rupture of membrane. Now, in iatrogenic, we are sometimes forced to terminate the pregnancy before term when there is an impending danger to mother or the life of the fetus. And preeclampsia with HELLP syndrome, eclampsia, placental dysfunction with the growth retardation, and antepartum hemorrhage, severe resource isoimmunization, though less now, and maternal diabetes, liver damage, and all these are the indications of iatrogenic or the termination of the pregnancy. Now, previous preterm birth, strongest risk factor for future preterm birth. If there is one preterm birth, the next will be 14%. If there is 2 preterm births, there will be 28 to 42%. If there is 3 or more preterm births, the incidence will be 75%. A term birth decreases the risk of preterm birth subsequent pregnancies. Now, role of infection. The infections are mostly subclinical. And clinical chorioamnionitis, intraamniotic infection is 3 to 35, 6 to women and preterm labor. 40 to 50% women with a PROM, 60% in chorioamnionitis, multiple route of invasion, intraamniotic infection ascending from the vagina and the cervix. It does not need a dilated cervix. The organism can penetrate to the intact cervix. Hematological dissemination and retrograde sitting, and invasive medical procedures like amniocentesis and chorion venous biopsy. Now, what are the organisms? There are many organisms. Important words are ureaplasma, mycoplasma, chlamydia, gardnerella, group B streptococcus, and cervical herpes simplex 2 infection. And now there are 2 asymptomatic infections which are very important cause One is the asymptomatic bacteriuria, and another is the bacterial vaginosis. And that is why whenever lady comes for antenatal checkup, we must see the vaginal pH to diagnose, and then to diagnose the bacterial vaginosis, and then the urine examination for asymptomatic bacteriuria. Now, how infection produces preterm labor? There is controversies, but the fact is that the infection, when reaches, whether it is an ascending and transplacental or retrograde, it produces infections of the membranes, the decidua, and so. And these infective pathogens are recognized by our innate immune system. When this innate immune systems recognize them, there are two pathways. One is the maternal inflammatory response, and second is the fetal responsory response. In maternal inflammatory response, there is a liberation of the pro-inflammatory cytokines. And in this is interleukin 1, 1B, 1,6, 8, and TNF-alpha is important. Interleukin 1B is very dangerous. It affects in the deciduo-amniotic space and liberates prostaglandins F2-alpha, E2, and this prostaglandin, you know, the cause of cervical remodeling and contraction. And second is that there is a remodeling of the cervix and mild fetal remodeling. Now, there are certain organisms which, besides the prostaglandin, they produce matrix metalloproteases. There are 1, 3, and 9 are important. It is said that the 9 number is genetically predisposed. Now, they weaken the membrane, they produce apoptosis of the amniotic cells, and they disperse the matrix and the collagen. So the membrane become weak and there can be a rupture of the membrane. The maternal inflammatory response, there is the induction of pain and there can be rupture of membrane. About the fetal inflammatory response, this is another way we are showing how the cytokines are acting and producing contraction, cervical changes, rupture of membrane. The three main components contributing to labor, the cervical change, the uterine contractions, and activation of the decidua and the membrane. Now, pathologically events the fetal inflammatory response syndrome. So what in fetal responsibility syndrome is that there is a high level of interleukin 6 in the plasma, and this high level of interleukin produces fetal stress. There's a trigger sent to the fetal hypothalamus secretion of the CRH. CRH is supposed to be the stress factor. It is produced by placenta also. As the labor time comes soon, the level of the CRH also increases. Now this CRH stimulates the ACTH. ACTH stimulates the fetal production of the cortisol and fetal adrenal glands. Not only cortisol, there is also production of dehydroepiandrosterone. This dehydroepiandrosterone influx, there is a liberation of estradiol. The influx of the inflammatory cells into cervical stroma releases again cytokines, prostaglandins, cervical returning apoptosis. This estradiol leads to collagen degradation, regulates the gap junction formation, and there is a upregulation of the connexin 43 protein and parturition. The fibronectin, that is one important factor This is produced due to degradation of the extracellular matrix, detected from 32 to 36 weeks, and indicates the disruption of the chorioidal space. It can be diagnosed in the cervicovaginal fluid. If its level is more than 15 per cc, then it is an indication that there is a possibility of preterm labor. It's a negative result is a more prognostic than the positive. Now coming to the prevention, how we can prevent? We should prevent the contraction. We should remodeling of the cervix should be prevented. Now the prevention, there are three modalities to us. One is the progestogen, second is the cervical circlate, and third is prophylactic tocolysis. Last 18 to 20 years, there are a lot of studies and experiments and about the progestogen, that the progestogen, how it acts, or what should be the route, and whether it is effective or not effective, whether it is equal to cerclage, it should be given with the cerclage or not. Now the first is that how the mechanism, how the progestogen prevents preterm labor. It prevents in all ways. It acts in the placenta, regulates timing of the labor by controlling the CRH, the stress hormone produced by placenta. It acts in the amniotic fluid, limits the prostaglandin production. It acts in the frontal membrane, blocks the pro-inflammatory cytokines, induces apoptosis and prevents from. It acts in the myometrium and the cervix, suppresses inflammatory and inflammatory response to myometrium. Now about progestogen. Now progestogen, there is a natural progestogen, micronized, very small particles, and synthetic progestins. Micronized progestogen is the drug of choice. It can be used orally, vaginally, and synthetic progestin, that is a 17-hydroxyprogestogen caproate, is given intramuscularly 250 milligram weekly from 20 weeks to 34 to 36 weeks. Now various route, oral, intramuscular and vaginal. Oral we prefer in India because the rural people don't like the vaginal route. Intramuscular is painful. So vaginal route is preferable. There's a high concentration in uterus and endometrium. First uterine pass effort, minimal systemic side effect, good patient compliance, and self-administration. Now this picture shows you how the vaginal progestogen, which dissolves in the upper vagina, goes into the uterus and endometrium. Now there is the lymphatics and capillaries plexus that through that it very rapidly the micronized progestogen reaches the uterus and the endometrium. Now this is the micronized progestogen. Now about the studies. Now perinatology update 218 says that prophylactic use of injectable 17-hydroxyprogestogen suggested significant reduction in the incidence of preterm labor. However, down the years, there has been a move away from parenteral to other modes of administration, vaginal or oral. Many studies using vaginal progestogen have been published. However, in our country, most women are reluctant to use intravaginal medications, more so in pregnancy. They are more comfortable with oral route of medications. By what the chairperson infertility committee of Foxy says, they say that vaginal progestogen prevents preterm birth, crucial to improve outcome. We must identify the risk factors. Now, what are the risk factors before giving progestogen? One is the history of repeated pregnancy loss And second is that though we do a vaginal sonography and you find the cervix is less 2.5 centimeter or less than that, these two are the indications of using either a cerclage or a progestogen. NIP publication, the vaginal progestogen cervical cerclage for prevention of preterm birth in women with a sonographic short cervix, singleton gestation, and previous preterm birth. Now, earlier reports are saying that they are not effective in multiple pregnancy. Now we know that it is effective in multiple pregnancy, and it should be given even after the rupture of the membrane. Now, when you give the micronized progestogen associated with the trend towards a reduction in preterm birth and increase in the maternal serum progestogen. Now, adjuvant progestogen. Now, the question arises when you do a cervical cerclage, whether you should give adjuvant progestogen or not. Yes, one should give adjuvant progestogen because the pregnancy extends or continues up to 26 weeks. Vaginal projection decreases preterm birth. A meta-analysis and cervix meta-analysis including data from the optimum study. Now the cervical cerclage. Before this progestogen era, our only modality was the cervical cerclage. We used to do cervical cerclage when there was a history of preterm labors and their cervix was short. Nowadays, the history-oriented cerclage we do sometimes, but I give cervical progestogen. There is the ultrasonography guided, and last is the rescue cerclage. The rescue cerclage is one in which the progestogen in any form cannot have effect. We will do a cerclage and have done so many cerclages, rescue cerclage, that means the cervix dilated, membrane bulging, and it is imminent that the membrane may rupture in any time. And all these cases, a adjuvant should be given, that is, the progestogen should be given for again 34 to 36 weeks. With this we can continue the pregnancy at least for another 8 to 10 weeks. Tocolysis. There is no clear evidence that tocolytic drugs improve outcome. Therefore, it is reasonable not to use them. Use them only to gain few days would be put to good use of corticosteroid and in utero transfers. Only to those who benefit by gaining time to hospital or NICU transfer or not completed steroid course. This only extends the pregnancy to the 48 hours to 7 days. Now coming to the definite therapy in preterm labor, that is the corticosteroid administration. Corticosteroid should be given single dose antenatal corticosteroid to women between 24 to 34 weeks with a high risk of preterm birth. But betamethasone or dexamethasone. Now, antenatal corticosteroid should be given to all women whom an elective cesarean section planned prior to 38 weeks. Now, the question arises, there is an important question. Nowadays, we find that the repeated doses of corticosteroid. We find that even corticosteroids are given weekly. All the studies, the RCOG, the WHO, the NICE, the studies, they recommend that we can give another dose of corticosteroid only. Second dose, if the first dose has elapsed 14 days and there is still a possibility of preterm labor within 7 days. A rescue dose is also given in 7 days. Administration, now another is the neuroprotection. I don't have much idea about the neuroprotection. Dr. Rajesh can tell us that what is the role of neuroprotection. That is the magnesium sulfate intravenously has a significant reduction in cerebral palsy in gestational age before 30 to 28. Administration, even for multiple gestation, for expected delivery within 24 hours, even in PROM, can be administered 4 hours before delivery. Now, regarding the ROP, I'm not going to tell about ROP. There is a learned people to discuss about the ROP. Now, one thing is that I like to see earlier all the reports, they are not advocating the estrogen in multiple pregnancy or after PROM. But nowadays we know that we give in multiple pregnancy also, we give progesterone, we do a surclage because the 30% of the cases of the multiple pregnancy, that is a preterm delivery. And we also give progesterone, and even after rupture of the membrane, we give progesterone in the progesterone and corticosteroid. It does not induce or there is a production of infection into the amniotic cavity. Now, thank you very much for your silent hearing. And I thank the organizers once again for honoring me and inviting me in the webinar for giving this my.
Thank you, madam. Thank you, madam. Thank you very much. And madam, please be with us till the last, because we want you to be with at the time of Dr. Rajesh's presentation also, and Dr. Bibbhuti Kashyap's presentation also. And in the last, we have organized a nice award ceremony. So we want you to be till the end, to be present till the end. And now I am Navneet ji. I'm inviting now the Foxy chapter and IAP chapter, pediatricians and gynecologists or OBGYs, to ask questions from madam. And please, Dr. Nivedita, help madam. And the OBGYs first and pediatricians, if you have any question regarding madam's presentation,
any question, or they can add also. They have their own experience.
If they have their own views,
they can share their own experiences also.
Obstetricians, there are a lot of obstetricians here. If they want to share their view, they can share. If they want to ask any question from madam, they can ask. All Navneet ji, इन लोगों का वीडियो ऑन कर दीजिए. All obstetricians and pediatrics. Pediatricians आइए.
ऑन है, सबका ऑन है.
हाँ, सब है. डॉक्टर प्रकाश, डॉक्टर शैलेश, डॉक्टर मनसैया, डॉक्टर राजीव शरण. प्लीज मैडम से कुछ क्वेश्चन पूछना है आप लोग को.
Ma'am, I have a question. This is Dr. Rajni from Jamshedpur. So when you talk about extending the pregnancy to a certain point, with a view to ROP, is there a target weight that we are looking at for prevention of ROP?
Yes, because you know that the ROP is a basic factor is the prematurity. If we can prevent prematurity, we can perhaps prevent ROP.
Is there any weight criteria that we should be looking at specifically for ROP? I know that in some studies they have mentioned that below 800 grams, the severity of ROP is much more, and perhaps at 1.25 kgs, it's a little less. Do we have any data to back this up?
Nivedita? Yes, we know that. If the baby is less than 30 weeks and weight is less than 1.5 kgs, and the possibility of ROP is more. So our effort will be to increase it at least up to 32, 34 weeks.
Thanks.
Unmute yourself. Unmute yourself, Nivedita.
Okay. Can we ask a question?
Ji. Yeah, please go ahead, ma'am.
Ma'am, there are two
Madam?
opinions. In outer countries, the 1750 is the weight which is cut off, and in India, 1500 grams is the weight which is cut off. But in extremely low birth weight babies, where the 1200 is the cutoff for ROP.
I think in the presentation of the pediatrician and the ophthalmologist, this will be addressed in more detail.
Dr. Bibhuti, what do you say? Dr. Bibhuti, what do you say about the weight?
Are you asking me or Dr. Bibbhuti Kashyap? I think Dr. Bibbhuti Kashyap should take this.
Bibhuti aims.
Yeah,
Kashyap.
Dr. Bibbhuti Kashyap.
I mean, I'm not too sure about the exact weight cutoff and the severity, but of course, with lesser baby weight and earlier preterm deliveries, the intensity and the severity of ROP is more. But then again, it also depends on the kind of NICU setup you were in and the kind of oxygen supplementation that you're getting. So it also depends on that. Yes, earlier births and lower birth weights do have a negative impact on the outcome of ROP vis-a-vis the intensity. But the exact cutoff that Dr. Rajni ma'am is talking about, I'm not too sure of.
I have got a clarification to say that in India, even on the higher birth weight, we are getting ROPs. So it was quite well discussed in the national forum, and we felt that even above the weight of, let's say, 1500, one has to go for ROP. Anything below 2000. Anything below 2000. Below 2000.
I add something. I have done a little bit of research on it. The data says of Indian scenario, if the birth weight is less than 1500, it is 35% around ROP. And if it is less than 1000, around 60 to 65%. This is the national figure of ROP in India.
Yeah.
Okay. What sir is trying to say, Mitra sir, is that I mean, corroborating with what I had said, with lower birth weights, the intensity and severity of ROP increases, but it does not rule out this finding does not rule out occurrence of ROP in higher birth weights. That is why RBSK program has issued a cutoff of 2000 grams. For ROP, but exactly a cutoff below which the ROP intensity is very high. I mean, corroborating with what Dr. Rajni ma'am is asking, that weight cutoff I'm not too sure of.
Dr. Rajesh, Rani Children is there.
I will discuss all this in my presentation.
Huh?
Yeah, in his presentation, he will be discussing
all this in my display.
I will also have to ask one question, madam.
Yes, ma'am, please go ahead.
Yes. By hearing the data from different studies, it is seen that this retinal problem is associated with all types of preterm births. So whether it is very severe preterm or the intermediate or the moderate one, these different data are showing. So I want to ask whether all the preterm babies should be examined ophthalmologically routinely, or there should be selected cases.
I will be discussing that in my presentation.
Okay, Dr. Bibhuti Kashyap will be discussing this part in his presentation, madam. So, Dr. Bibhuti Bhushan, should we proceed ahead?
Yeah, I think we should go ahead. We should go ahead.
Dr. Smriti Nath want to say something?
Yeah, I just want to ask one question.
Yeah. Yes, ma'am, go ahead.
Shobha, madam, is magnesium sulfate got any role in the prevention of the ROP?
Not a prevention of ROP. It prevents the neurological problems. But I have said that we don't have any experience. I am asking our pediatricians whether they have any experience. Other countries are using Maxal to prevent the neurological problems in newborns when it is a premature.
It's very clear, ma'am. It is very clear. Magnesium sulfate doesn't have any role in prevention of this ROP. It does have very clear benefit in preventing intracranial complications in the preterm. It's very much clear. So no doubt about it.
Okay.
There's no role in preventing the PRO.
Yeah, intervention storage it is prevents, I think.
Yes, it has a very definite and parallel role as steroids. As we give steroids, magnesium sulfate has a similar role in that, preventing intracranial hemorrhage and all those things.
Okay, okay, thank you.
Now
One
I
more
invite, okay.
One comment from my side.
Yes, ma'am, please. Please go ahead, Maya, ma'am.
Yes. Is there any selection of applying this tocolytic drug or progesterone or something? Is there any contraindication of the use of these three preventive aspects for the preterm labor?
Now, tocolytic drugs are nowadays very rarely used.
Yes.
It is used to transfer the baby to a specialist center, or when we have not given corticosteroid, we at least took 2 days to give the corticosteroid. And in the tocolytics, we are not giving vitamimetics nowadays. Earlier days, we used to use vitamimetics very frequently. There is a possibility of pulmonary edema and so on. Nowadays, even whenever we use with the calcium channel blockers.
So this is the first line of tocolytic drug, the nifedipine.
Madam, does corticosteroid help anyway in ROP or only in lung maturation?
Corticosteroid prevents mostly all the complications of the prematurity. Maximum is the respiratory distress. And you know that respiratory distress, when you treat for respiratory distress, you give oxygen, and it is very difficult to find out what is the optimal level of oxygen. That can lead to prolonged oxygen therapy. That can lead to ROP.
Thank you, madam.
Well, now I invite Dr. Rajesh for his presentation. I'm sure after his presentation, many of the questions will be answered that we are thinking of. So, yes. Dr. Rajesh, please share your screen and go ahead with your presentation.
Are you visual?
Yes.
Yeah. I thank first of all for inviting me as a speaker in this webinar. And this story of ROP goes long back. I joined PGI in 95 January. In 95 January, that time itself, there was an active ROP program going on in PGI Chandigarh. You can imagine, 1995. And first workshop, national workshop for ROP was organized in AIMS. It was in 1998. I attended that. It was the first ROP workshop along with neonatologist and ophthalmologist. So it is almost 25 to 30 years history is there in India. And initial only the PGI Chandigarh and AIMS and one center from Chennai, the Child Trust Hospital, they were reporting the case. Nowadays, the neonatal care has improved all over India. You can imagine that in Jharkhand, neonatal ventilation is going on in 6 cities. You can imagine. And 20 years back, I know hardly anybody was there. And more than 20 hospitals are ventilating the babies. And neonatal survivals have increased like anything, especially in the babies who are less than 1500 grams. And also there are enough data. So enough data to show that as you increase the survival of smaller babies, the incidence of ROP goes up. And if you have infant mortality rate less than 20, 50% of the childhood blindness is due to ROP. So if you as your neonatal care will improve, ROP incidence will go and solution to childhood blindness is going to increase.
Dr. Rajesh, just 1 minute, I'm interrupting you.
Yeah.
I request all the panelists to kindly mute themselves. It is very disturbing when a speaker is presenting his paper. So you kindly mute, all the panelists, kindly mute yourself. Thank you. Please go ahead, Dr. Rajesh.
Okay. So we have 3 epidemics of ROP in the history. Currently, we are in 3rd epidemic. First epidemic was in 40s to 60s. where we used to give a lot of oxygen without monitoring the babies about the toxicity of oxygen. That was that time we used to call them at fibrolateral hypertension. Then we have a second epidemic, which in 1970 to 2000, it happened in developed countries, and especially the babies were less than 1,000 grams. And as their care improved, the incidence of ROP in these babies also is going to go down. The third epidemic which we are talking now is started after 2000, and mostly in the third world countries with the starting the neonatal services. But the neonatal services are not that of high quality services, and it is compromised neonatal care. And this, in the scenario of this compromised neonatal care, the bigger babies are getting ROP. This is mostly we talk about babies who are 1,000 to 1,800 grams and getting ROP, and even the babies of 2 kgs getting severe ROP requiring the lesion. So what is the difference between developed and developing countries? This green circle, this is UK, Canada, and US. And this is a red one. This is from the study from India. The mean gestational age of the babies who require intervention, threshold ROP, is only 25 weeks in Western countries. But in India, you can see the mean gestational age at birth in India who requires therapy for ROP, threshold ROP, is close to 30 weeks. That's why once you see the books and recommendations from the various countries, you get confused. If you see the American recommendations, they are different. If you see the WHO recommendation, they are different. And if you see the Indian recommendation, they are different. Because the subgroup of babies who are getting ROP is different in different countries in different parts of the world. That's why we will focus only on the Indian recommendation because they are specific to India. So whatever limited data we have from the developing countries, especially in India, the incidence of any ROPs in less than 1,500 grams birth weight babies is around 30%. Some will say even 40 to 50%. So it's such a high incidence. And the blinding ROP, which will result in the blindness of the babies if they are not managed properly, is somebody will say 5 to 7, and some will say it is 5 to 10%. Even the publication from Government of India, it says around 5 to 10% of ROPs are blinding ROP. So we have to recognize the ROP and treat it effectively to prevent the blindness. Again, what is the extent of problem in India? Almost, Madam has said these figures. I will again repeat it, around 3.5 million, 35 lakhs babies are born preterms. Data is around 10 years back data. And if not managed properly, almost close to 1,800 babies will go blind due to ROP. If we extrapolate the data to our state, Jharkhand, we have population of close to 4 crores. Birth rate is around 23.5 per 1,000 live births, per 1,000 population. BLBWs are that is less than 1,500 grams, 3% of the total live birth. Survival will say around 60 to 80%, that is 16 to 20,000 babies of less than 1,500 grams will be surviving. And any ROP, if you take in those, it will be close to 5,000 even for the state like small state like Jharkhand. Blinding ROP will be close to 1,600. And we know if we don't treat the threshold ROP, 50% of them will go blind. So the blinding ROP, if not treated, but blindness due to ROP not treated, will be close to 846. So this is what we get if we don't treat, we don't manage the premature babies ROP properly. Both eyes, you have retinal detachment. So in Jharkhand, more than 850 babies are likely to become blind due to ROP if they are not managed properly. You can imagine the extent of problem what we are sitting in the state of Jharkhand. What is ROP? ROP is basically, it involves the cessation of normal retinal angiogenesis and a subsequent hyperproliferative neovascular response to neonatal ischemia. I will come later on this. The hyperproliferative response progresses serially through well-defined stages, and in its most aggressive form, it causes detachment of retina. So it will start from stage 1, slowly go to stage 2, 3, 4, and may end up having stage 5 ROP, that is detachment of retina. So what is the normal development of retina? At 16 weeks, the vessels at optic disc will start growing. At around 36 weeks, they will reach the nasal side of the retina. And 40 weeks, that is on complete pregnancy, it will reach the temporal side of retina. If you take an example of babies of 26 to 28 weeks, what will happen? This green area is showing the area where the vessels have matured. But this red area is left in zone 2 or zone 3. Still, they are prone for developing ROP. The smaller the baby, like 24, 25 weeks, the green area will be further small. So, a lot of retina is not developed in premature baby, and this retina is prone to developing retinopathy of prematurity. What is the pathogenesis of ROP? Due to premature birth, what happens? There is a IGF-1, insulin-like growth factor 1, which baby was getting for the mother, that is stopped. The polyunsaturated fatty acid omega-3, which baby was getting through mother, that is stopped. These two are involved in your vessel development of the retina. Again, what happens is VGF, vascular endothelial growth factor, and erythropoietin. Oxygen causes suppression of these two, vascular endothelial growth factor and erythropoietin. So oxygen, so these four factors, IGF-1 less, polyunsaturated fatty acid less, and the suppression of VGF and erythropoietin causes the vessels to stop growing. That is the first, we say, phase 1 of the ROP. Then comes what is the second phase? Second phase, what as the baby is maturing, what happens? This retina, this part of retina, which is not vascularized, whole retina is now having increase in metabolism. And there is an increase in metabolism, but because the retina is not vascularized, there is a lot of hypoxia is happening here in the non-vascularized retina. Because of this, there are growth factors. They start coming up in their eyes. That is, there is increase in IGF-1, increase in vascular endothelial growth factor, increase in erythropoietin, and this gives a strong signal for vessels to grow. And this growth is abnormal. This you have to realize. This growth is abnormal, and the signal is coming through this hypoxic retina. That's why we do laser here. To stop this vessels growing, we do the laser here. We burn this retina so that the stimulus for neovascularization is stopped. What can we do? In early phase, if you give controlled oxygen, see, there are animal studies to show that if you supplement IGF-1 and supplement the polyunsaturated fatty acid, the vessels growth is better. But it has not come into the practice, neonatal practices. But this thing, that the fact that the oxygen suppresses the vascular endothelial growth factor and erythropoietin, that we can control. This is in the hand of pediatrician and neonatologist to control the oxygen. If control oxygen will prevent the suppression of VGF and erythropoietin. This is very important. If you control the oxygen, the suppression of vascular endothelial growth factor and erythropoietin will go off. If at all we reach in second stage, this is the early phase, second stage. What is there? We have a lot of vascular endothelial growth factor, so we can give outside inhibitors. This ophthalmologist nowadays they are giving it anti-VGF. We can give and we can stop, we can suppress this increased level of vascular endothelial growth factor. So it is a nutshell of the what is the pathogenesis and what is the implications in prevention and treatment. So how does the ROP behave? See, ROP starts from say maybe 25, 26, 30 weeks, 32 weeks, and they peak around same, whether baby is born 24 weeks or baby is born 32 weeks, the peak is around 38 weeks. And so roughly 36 to 38 weeks when they will mature, they'll have maximum ROP. And after that, even if you don't treat it, they'll spontaneously start going in. But some will progress and cause detachment of retina, but 50% of them is slowly and slowly starts getting better itself. So that's why we see the older recommendation, now also older recommendation, like say 15 years back, 20 years back, they used to say the babies who are born around 26 weeks, they should be screened at 8 weeks of age. Babies who are born at around 28 weeks, they should be screened at 26 weeks, at 6 weeks of age. Babies who are born around 31 to 32 weeks, they should be screened at 4 weeks of age. So that's why if you go through textbooks, they'll have all this, still will have all these recommendations. But nowadays, universally, 4 weeks is the answer. But there is a special form of ROP that I was telling you, the traditional, what is teaching is there and what we experience. But there is a special form of ROP that is known as aggressive posterior retinopathy of prematurity. This is a severe form of ROP which is characterized by fast progression to an advanced state in zone 1 and posterior zone 2, can quickly lead to total retinal detachment. This is also known as rush disease, we used to call them previously. And this can develop as early as after 14 to 15 days of life. This is very important, especially for pediatricians, to realize the AP-ROP can develop as soon as 15 days of life also. So what is our responsibility as an obstetrician, as a pediatrician, as an ophthalmologist? Our responsibility is first of all to prevent ROP in the hand of obstetricians and pediatricians. Other responsibility is to prevent the progression of ROP by screening and interventions. It is the responsibility of pediatricians and ophthalmologists. How can we prevent the ROP? Madam, have already discussed about the prematurity. The two major risk factors for development of ROP is prematurity and hyperoxia. Prematurity, especially babies who are less than 1500 grams. And oxygen, hyperoxia. So this part, Madam has already discussed in length how to prevent prematurity. So prevention of prematurity is the responsibility of obstetricians, and prevention of hyperoxia is the responsibility of neonatologists and pediatricians. Other risk factors are grouped in 3 groups: fluctuating saturations, prolonged oxygen therapy, ventilation, intraventricular hemorrhage, respiratory distress syndrome, neonatal enterocolitis, poor postnatal growth, sepsis. Third group is apnea, anemia, blood transfusions. I'm not going to go into detail how these factors cause ROP. So, Madam, we discussed about the antenatal steroid. Antenatal steroid will cause less of the RDS, less of the IVH. It will cause less of the babies who are going on ventilation. It will cause less of the babies who are needing prolonged oxygen, less of the lung disease, severe lung disease, so less of the fluctuating saturation. So antenatal steroid is a major factor in decreasing the incidence of ROP. Second one is NEC, postnatal growth and sepsis. Mother's milk. This is very important. Once we care for premature babies, mother's milk is very, very important because it has been shown by many studies that it prevents necrotizing enterocolitis by many folds. Growth is much, much better if babies are getting mother's milk as compared to your formula milk. And when the septicemia, late onset septicemia is much less if babies are getting mother's milk. Then blood transfusions there are enough evidence to show that if you give the adult hemoglobin, that causes lot of oxygen to be released to the tissues, and that causes increased incidence of ROP. So we should be conservative in giving blood transfusion. We have, like, if you see the hemoglobin of 11, give blood transfusion like that. Now, it's not like that. There are strict guidelines available for the blood transfusion in the neonates. So antenatal steroid, again, this responsibility of by the obstetrician gynae. Again, I want to comment on antenatal steroid. You should not, there are many obstetricians, they keep on giving antenatal steroid weekly from 26 weeks, 27 weeks, 29, every week. That is bad. Initially, like few years back, it was recommended that you should give only one course. Nowadays, as Madam told, the recommendations there, limited recommendation for second dose also after 14 days. So at the most 2 doses should be given maximum. Repeated, what is the harm of giving repeated doses? It causes neuronal apoptosis in the brain, and that causes developmental delay in newborns. So the weekliest antenatal steroids should never be given. Mother's milk, again, the responsibility of obstetricians and pediatricians. Obstetricians can do the counseling about the giving the milk and sending them to an ICU for the babies. And pediatricians also, they should counsel the mother, they should use the breast pumps. So to have a more of the express breast milk for the babies. So again, this blood transfusion, neonatologists and pediatrician responsibility to be little conservative in giving blood transfusions. So again, I am stressing these 2 factors, antenatal steroids and breast milk. They are the most important 2 protective factors for the retinopathy of prematurity. Coming to oxygen and ROP, this is a very old study, 1956, the era of uncontrolled oxygen. It was a beautiful study. One, they gave conventional oxygen, lot of oxygen. Second group, they gave oxygen. That time pulse oximeter was not there. So what they used to do, if baby has cyanosis, visible cyanosis, they used to give oxygen. If visible cyanosis is not there, they stop the oxygen. And the study, what they say, survival was almost same, 22 and 25%. ROP incidence was remarkably different, 72% and 33%. The stage 3 to 5 ROP was 23%. In curtail, it was only 6%. Blinding ROP was 11% in conventional oxygen and only 2%. And this landmark studies established the role of hyperoxia in causation of ROP, definitely. Coming to the latest study, there are a lot of trial, good quality trial available in the neonatology about what the saturation should keep. Low saturation, high saturation, 85 to 90 or 90 to 95. There are 5 studies available, meta-analysis available, and all of them says that the restricted oxygen is better in preventing the ROP. So there is no doubt that you should have a controlled oxygen given to the babies. What should be a target? This is very important. 90 to 95%. If the oxygen target should be there in the baby. If you go to an ICU, if baby is any saturating 98, 99%, you have to remind the nurses, please have mercy on the eyes. So always 90 to 95%, and that is setting. You can keep the alarm setting on, alarms on, and you can set the alarms 89 to 95%. So whenever your alarm crosses 95, 96, 97, the monitor will keep on giving alarm, and they will and also you should instruct and you should empower your nurses to decrease and increase the oxygen depending on the saturation. It's not like doctor ne bola tha 2 liter dene ko main kaise kam karu. This is not like this. You should empower the nurses so they can regulate the oxygen on the basis of saturation. This is very important. So there are 3 factors which we can control in the nurseries. One is always use pulse oximeter whenever you are giving oxygen to a premature baby. It is almost like a criminal offense if you are not using a pulse oximeter in a premature baby or if you are giving oxygen. If you can, they can go, if baby develops ROP and they can go to the court and court will ask you what is the saturation level you show. You cannot provide. So we have to have a pulse oximeter attached to a baby who is premature and getting oxygen. Then again, nutrition. Nutrition, you should be aggressive enough in giving total pattern nutrition, early feeding, so that the baby does not have poor growth. Poor growth is associated with the ROP. Again, this is now COVID era. We all keep on washing our hands, hand rub. So same thing we used to do in NICU for long, almost 30, 40 years we are doing. So keep on washing your hand and asepsis precaution as much as possible and prevent the sepsis. This is the biggest killer in our Indian NICU. And if once the baby develops sepsis, they have a high chances of developing ROP. Then the second part, it is how to recognize the baby with ROP and what to do. There are many ways they do, like we have indirect ophthalmoscopy, maybe direct we used to do it as a resident in PGI. I used to do direct and look for the plus signs that time. Nowadays we have red cams available. Even the Indian red cams have come in the cheaper prices. They are easily available in India. And this, I will talk on the basis of this guideline. It's a beautiful guideline. This has come from our National Neurology Forum in this year only, January 2020. And this screening and management of retinopathy of prematurity. What they say, so the blindness or severe visual impairment in less than 32 weeks, if screening is not done, 365, almost 1/3, 35% of the babies will develop ROP and blindness and visual impairment. And if with screening, almost 146 per 1,000 babies. So 15% of babies will develop blindness and severe visual impairment. If you talk about the bigger babies, 32 to 36 weeks babies, these babies are not talked about by the Western countries, colleagues. They will talk only about this. But for Indian context, these bigger babies, 32 to 36 babies are very, very important. If screening is not done, 10% of the babies will have blindness or severe visual impairment. And if it is screening is done, it is almost 4% only. And so one thing we have to realize that in spite of your best efforts by obstetricians, pediatricians, and ophthalmologists, the many babies will go blind. It is not like that if you are doing everything properly, you can eliminate the ROP. It is not like that. But with the proper screening and management, you can 2/3 of the babies' eyes you can save. But still 1/3 of the babies' eye, we cannot save it. This fact has to go in the mind of all obstetricians, neonatologists, pediatricians, and ophthalmologists. Because many times what happens, this baby has become blind. It is a fault of ophthalmologists, fault of pediatricians. Not in spite of our sincere effort, many babies will go blind. But we can prevent 2/3 of them from becoming blind. This is important. So next question, whom to screen? This is a Government of India guideline, and the same thing is endorsed by our NNF, India Evidence-Based Guideline. All babies who are born less than 34 weeks at birth, if baby's gestational age was less than 34 weeks, even 33 weeks and 6 days, all babies, even if they are healthy, no problem, babies are born and taking feeds, went home, the baby has to be screened. Many 33 weeks babies will develop. It will be delivered in nursing homes. They will be all right. It may be 2 kg. Taking feeds, they will be discharged from the nursing home itself. But all the babies who are less than 34 weeks have to be screened for ROP. Second criteria is any baby at birth less than 2 kg Many babies like 1.7, 1.8 kg IUGR babies, they'll be all right. They will be delivered in small nursing homes, taking feeds and discharged home, many a times without showing the pediatrician also. So it is the responsibility of obstetricians also to remind them that less than 2 kg baby this baby has to go to ophthalmologist for screening for ROP. Third one is bigger babies. So 34 to 36 weeks babies, what to do? If any risk factors are there are 7 risk factors. If any one of these are present, these babies has to be screened. Need for respiratory support, any CPAP, high flow, ventilation, oxygen therapy for more than 6 hours, septicemia, proven septicemia, not the suspected, apneic episodes if babies are having, if baby received blood transfusion, if baby received, even 35 weeks baby had anemia because mother had placenta previa and baby hemoglobin was 10 and baby received blood transfusion, 36 weeks baby, this baby also need to be screened for ROP because adult hemoglobin causes increase in oxygen delivery to the tissues and that will cause ROP. So any blood transfusion in premature babies, even if baby was asymptomatic, there has to be ROP screening has to be done. Extended transfusion, babies if required, or nowadays very less extended transfusion are done. They have to be done. And last one is unstable course as determined by the if treating pediatrician says this baby has to be screened, it has to be screened. That's all. It is a discretion of treating pediatrician. If baby is less than 37, if he says it has to be screened, has to be screened. That's all. So if babies are less than 34 weeks, it is or, not and. This has to be remembered. Many times what happens, 35 weeks baby, 1.8 kg. You will say, nahi, 35 weeks screening kyun karayenge? Nahi, it is or, not and. So any babies are less than 34 weeks or less than 2 kg or these risk factors in bigger babies, they have to be, these are the very most important slides for obstetricians and pediatrician, most important slides. This webinar, if we are successful in giving this message, then this webinar is successful. Then when to screen? The traditional one is 4 weeks after birth and 30 din Rosni ke. This is a slogan given by Professor Jalani from LV Prasad. And 30 din Rosni ke means baby has to be screened before one month of age. That's all. For the ROP, any premature babies, with what I have said in the previous slide, has to be screened by 1 month of age. 30 din Roshni ke. But I talked about the ROP, AP ROP and aggressive posterior ROP. So babies who are less than 28 weeks or if gestational is not sure, babies with birth weight less than 1200 grams, they have to be screened in 3rd week of life. 3rd week of life, after between 2 to 3 weeks. 3rd week of life, if baby is in an ICU. Many a times we used to say, "Yaar, abhi to time nahi hua hai, ROP develop nahi hoga." It takes 4 to 6, at least 4 weeks to develop ROP. Not like that. So if the special babies, all babies who are less than 28 weeks, all babies, if gestational is not sure and the birth weight is less than 1200 grams, has to be screened in 3rd week itself to know the ROP. In I think last 10 years, I would have seen at least 10 to 15 AP ROP in our unit. So this is very important to know this, that especially for pediatrician and neonatologists, 3rd week, even the 15 days, 16 days. Usually what happens in every unit, you have one fixed day allot for the ROP screening. Like we have usually Thursday in our unit for ROP screening. So in that Thursday, any baby who has less than 28 weeks, less than 20, is between 2 and 3 weeks, they will screen them. So like that only many units follow the same protocol weekly in the unit screening. To conclude, ROP is a preventable in many premature baby, but again this message is not 100% preventable.
Jaldi aao.
Primary prevention is responsibility of obstetrician and pediatricians. Prevention of prematurity, monitored oxygen therapy, giving mother's milk to premature baby, and prevention of sepsis. Secondary prevention means once ROP has developed, the responsibility of pediatricians and ophthalmologists, screening at the appropriate time, and proper screening and treatment. I know many of those would have seen this photograph of a singer, a great singer from America, Steve Wonder. And I just called to say I love you with the most famous song. He was a premature baby, given uncontrolled oxygen, developed ROP, but still he is well renowned. Even if you develop ROP, you should not lose hope. You can become as famous as Steve Wonder. But somewhere I read one editorial that heading was ROP, we just called to say we don't love you. As a pediatrician, as a neonatologist, as an ophthalmologist, we don't want ROP in our babies. Thank you. Thank you for calling me. Thank you.
Thank you, Dr. Rajesh. That was a wonderful presentation. I'm sure nobody could have done it better than you. And
Yes.
I'm also sure that many of the questions have been answered by you, which many of the panelists were thinking of. But I invite the pediatricians on the panel and even the gynecologists and ophthalmologists, whoever wants to ask or anything. It was an extensive presentation and wonderful presentation. I'm sure everybody has been enlightened. But
Yes.
any queries will be taken.
Yes, Dr. Rajesh, I'm Dr. Smita. Actually, really, it is an excellent presentation. Yeah, last year also we got in our institute 60 cases. We have done the ROP screening. And out of that, we got 15 ROP cases. And we are lucky that in Jamshedpur, we are having Dr. Bibhuti Bhushan, who is doing our ROP checkup. But I got one question that in 34 to 36 weeks, babies with risk factor, generally we are not following strictly. So what should be the screening time? At what age we should send this baby for the screening? Just before discharge or any criteria is there?
4 weeks, 30 दिन रोशनी के before 1 month of life. And also, madam, like if there is official guideline available, 34 to 36 weeks babies with any risk factor, you have to screen for ROP. That has to be done. Because once they develop ROP and they go to the court, you won't have any answer. Okay. And people have been fined up to 2 crores. Suits have been given.
Yes. So my question is that what time shall I send? After 1 week?
4 weeks. 4 weeks of age. 4 weeks of age.
Okay. 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 Thank you.
I have a question. So I have a question to Dr. Rajesh. Sometimes the baby needs sedation for longer durations of laser for AP-ROP. And sometimes the baby needs general anesthesia for stage 4 ROP or 5. And sometimes baby is very systemically ill, critically ill. So what systemic parameters do you intend to correct so that the baby can be taken up? At least what all those parameters are there, which you will look for to stabilize the baby and send to the, making the baby fit for the surgery.
There are 2 ways to do the laser. The traditional way of doing is taking to the operation theater or nearby room, separate room, and do the, if you have portable laser, you can go to laser. Other way, baby is very sick, we do in NICU itself sometimes.
No,
but
no,
the
my question is...
most important parameter, I've answered that. The hemoglobin should be more than 10. Babies should not have active septicemia. Babies should not have active apneic episodes. These 3 things, no active apneic episodes, no active septicemia, and hemoglobin should be more than 10. If these 3 parameters are there, you can take the baby to the operation theater, no problem.
Okay.
Dr. Rajesh, I just wanted to ask, this is a very silly question actually, the parents normally ask. So if the baby is diagnosed on first or second day, we have sent for ROP, suppose baby is diagnosed for ROP. Now the baby has to continue on oxygen or not? Up to 3 to 5 days, somebody says you can continue the oxygen for 3 to 5 days, somebody says 5 to 7 days. Is there any take on?
No, there was a beautiful study. It's called Stop ROP study. In that, what they have said, that if you see the pathogenesis, now once baby has developed ROP is in stage 2 pathogenesis. That time is hypoxia is the main, hypoxia is the main thing. If you give oxygen, it will correct the hypoxia. The Stop ROP study has shown that if you give oxygen, if baby has ROP will become better. It is good for ROP. If you give oxygen when the baby is in more than 2 weeks old or 3 weeks old and baby has ROP, giving oxygen will prevent the progression, or it will slow down the progression of ROP, but it will affect the lungs, it may affect the brain, it may affect the gut, because the hyperoxia can cause bronchopulmonary dysplasia in the baby. Hyperoxia can result in necrotizing enterocolitis. Hyperoxia can result in the intraventricular hemorrhage, brain damage. So that's why if you are giving oxygen, if your parents are asking, continue oxygen, there is no harm, no harm. For ROP point of view, it is better for ROP. ROP will become less severe if you give oxygen once baby has developed ROP.
Sir, I have a question, sir. Sir.
Okay, Dr. Vikas.
As you said, sir, there is phase 1 and phase 2 of ROP. So, in some bigger babies, not the premature ones, if there is proper screening is done, we see that the threshold condition of the ROP. The ophthalmologist has screened that now it is a threshold condition. It is going into the phase 2 part. So, in that situation, instead of going for the restricted oxygen, we can go for a more of an oxygen. There are studies they're saying that give a reluctant oxygen that is going to help the baby in normal angiogenesis in the later part.
It's the same as the previous question. Like giving oxygen will help the ROP.
The preterms will be damaged, but the larger babies are missing.
If they are on oxygen, oxygen has to be continued, but not like you are maintaining saturation 100%. But again, it should be given, the controlled oxygen should be given, because it can, giving more oxygen may harm brain, lungs and the gut. So it has to be given controlled oxygen, even if baby develops. So Stop ROP has shown this. So no use of giving liberal oxygen once the baby has developed ROP.
Sir, one more question. Recently, there has a lot of studies going on regarding use of propranolol in preventing ROP. What is your
it's still in the
experimental stage.
In animal studies, they have shown that it prevents the development of ROP, but still we are not sure in the newborns.
I have a question. Yeah, please continue.
Yeah, sir, I have a question, sir. You told about the use of steroid, and you said if we give more than 2 steroids or weekly steroid, it will have neurodevelopmental issues, sir. First question is this: how far is it? Like, can we give what is the recommendation for steroids? First, secondly, sir, what is the role of steroid in preventing ROP?
As madam also told that 2 maximum doses of steroid you can give, 14 days apart. That is the maximum you can give. And second question,
like the cause of it causes neurodevelopmental issue.
Yeah, the developmental issue, neurodevelopment is definite, because steroids are shown to be causing the apoptosis of newborn neurons in the developing brain. So that causes developmental delay. And antinatural steroid helps in many ways in preventing ROP, but not that.
So is it not that we are giving 12 hours apart 2 doses of either betamethasone or dexamethasone, or you are recommending only 1 dose?
No. That is taken as one course. I am talking about the
course.
courses.
Fine. Okay, fine. Right. Okay. That's okay, sir. That's okay. Thank you, sir.
Dr. Rajesh, I have got few questions for you. Excellent presentation from you. I think I am audible.
Yes. Dr. Mansaria, please go ahead.
Yeah. You see, there are many, as far as ROP is concerned, like for last 2 years in United States, there were only 1,400 or 1,500 around blinding cases of ROP, though the total incidence was around maybe 15,000 or so. And the figure is almost static for last few years. My answer question is that in spite of being given oxygen in their ICUs, the ROP level has almost remained same. So now what they are saying is that oxygen is no more a factor there. It's not a villain anymore now. Because now we are giving in most of the centers, because of the advent of pulse oximeter, most of the pediatricians are giving it below 100 only. It may be 97, 96, 98. Yeah, I agree with that. So now as a pediatricians, we should promote these factors, and other factors are more important in ROP, like sepsis, antibiotics, anemia, blood transfusions, or any other toxic factors during the pregnancy because of NEC or antibiotics given. Those have become more important factors, and oxygen has got a very small role to play. And this should be made home to all the, I mean to say, the general population, as well as to the judiciary and the administrative system also. In India also, now we have neonatal facilities have improved, and I don't think oxygen has got a very very important role to play nowadays. Secondly, my second question is that there are very conflicting, I mean to say, statements regarding ROP, not from your side, but also from different authors. Like anemia will promote ROP, where the oxygen supply becomes reduced. Blood transfusion because of adult hemoglobin will promote ROP because oxygen level is high. Like similarly, hypoxia, when it reduces the vascular endothelial factor, it will actually may promote ROP, whereas when you give more of oxygen, the vascular endothelial factors, they become more enhanced, they will also produce ROP.
It will depend on
even in your slide, you have given some conflicting, statements. But this is not from your side, I say, it's all the literatures. So what I mean is that there are so many conflicting factors. So that means oxygen was not only the culprit. It has become a big villain. It was a conflict, no doubt. You have given a report of 1956 or probably 1976 about the implication of oxygen, where you have shown that almost 1/3 of the cases, it comes down to 1/3 only if the oxygen is not given. But it doesn't hold true in 2000. I mean, so 2010, 2020 onwards. So I think we need to correct ourselves also that oxygen is not a major villain nowadays. This should be brought home to everyone. Other factors in prematurity, they are more important. Third question mine is, a child who is born before 31 weeks of age, do you still recommend 4 weeks after birth or 3 weeks after birth, as you said? I think the earlier recommendation was at 32 weeks of post-menstrual age, the first ROP screening should be done for those children who were born before 31 weeks of age. Earlier it was 27 to 31 because below 37, the survival rate was very, very low, almost negligible. Now, since the survival rate has come down to 24 weeks, even then we say it should be at 32 weeks, it should be at around 32 weeks of post-menstrual age. That is because the more the premature child is, it takes more time for the ROP to develop. Now, suppose if you are giving oxygen right from the very beginning, why should ROP develop later in preterm infants? That means oxygen is not only the only factor. It has the other factors because of the prematurity. The child was exposed to a lot of toxins, lot of antibiotics, lot of metabolic problems, hypoglycemia, hyperglycemia. Those were the major factors. What is your take about all these things?
Very good comments. And we should realize that ROP is a multifactorial disease. But oxygen is the most,
that should be made home to everyone, particularly
multifactorial disease, and oxygen is the most important culprit.
Not nowadays.
Because if you go to any NICU in the periphery, if 10 babies are there on oxygen, I'm sure more than 50% will be saturating 100%. More than, I'm sure. Then if you go to SNCUs, there are 20 babies, but they have only 3 pulse oximeters. They don't have enough pulse oximeter to monitor all the babies. So still, the monitored oxygen is very, very, very much requirement in Indian setup. Still, that's why we say oxygen is the most important culprit, because the oxygen is not, we don't give oxygen well monitored. If you are giving well monitored, that's why the Western countries have come down on ROP. So, and they have shown that if quality of care improves, your ROP incidence goes down.
Definitely, definitely. In spite of giving oxygen in peripheries also, if your care is improved. That's what I say. Other factors have become more important nowadays.
And other thing with oxygen and BGEF, there are two phases. First phase, especially the first 24 hours, if you give oxygen, there is a lot of suppression of vascular endothelial growth factors in the phase 1 of ROP. But if you go to phase 2, you give oxygen, it will going to help the babies. Phase 2, oxygen is going to help. But
that's
phase
what
1,
I said. Now they're conflicting reports.
But phase 1 is
some
going.
phase it helps. At some phase it deteriorates.
Because the pathogenesis is different in stage 1 and stage 2. And another question was the screening of the smaller babies. The smaller babies, 800 grams, 900 grams, we have to screen in 3rd week of life, only to exclude APROP. If you miss APROP, by the time they are 1 month of age, baby would have, retina would have detached. So if a baby is less than 28 weeks or less than 1200 grams, if gestational age is not sure, you have to screen in 3rd week of life, just to exclude APROP.
Yeah, that is ROP plus that we used to say earlier, the nomenclature was, right?
I think, sir, the Western countries have improved their screening strategies and they're intervening at the right time. That has prevented
Dr. Vikas, in spite of the improved screening strategies, I tell you, the incidence has not come down for last few years. It is almost same.
If it is screened properly, when the threshold is reached, when the ophthalmologist is intervening with such as anti-VEGF, that will help in improving that case. And also, that's the main thing. That is the main crux. Because the screening and intervention has improved in the Western part rather than in our part. That has made the difference.
What I would like to say over here, one thing what I have understood from Dr. Rajesh Kumar presentation and Mansaria sir presentation is, one thing is very clear, the biggest culprit is the preterm. Adding to it, obviously, oxygen, sepsis, and many other things comes into picture.
I think we should.
One of the biggest culprit is the preterm. If the baby is born preterm, the baby is most likely to get ROP even born at 34 or 30, less than 36 weeks. That is what I could interfere from you both, sir. One question to you, Rajesh, sir, is.
Now, Dr. Rajesh, I just wanted to ask, can we say that ROP can be prevented by the regulation of oxygen or oxygen tension? What should be the regulation? How to regulate the oxygen during how to the oxygen tension can be monitored?
It's always PO2.
See, in the babies, the oxygen has to be monitored from labor room itself. In the babies, nowadays, bigger babies, we say we don't resuscitate the baby with oxygen. We resuscitate with room air.
Yeah.
The premature babies, we have to resuscitate that with the 30% of oxygen. And this is very important for the obstetricians. Nowadays, in the Western countries, it is almost a law to have a blender in your labor room. If you don't have blender in the labor room, how can you give 30% oxygen? If you have to give 100% only. So blender has to be there in the labor room. If you don't have blender, you are doing a mistake. Again, when you are shifting the baby during transport, what they do, they give 100% oxygen. Again, you have to have blender during transport also. And NICU, most of the NICU, they have got blenders, everything available. But during resuscitation, during transport, these are the two places where we are almost 100% lacking in India.
And they say that the first 6 hours are most important.
Yeah, same thing. That's why I have emphasized on resuscitation.
Dr. Bharti,
6 hours are
more factor is there.
Labor room and
if the transportation is a prolonged one.
No, I think first we have to understand the basic pathology of the disease. What is the initial part, what is the pathology, and what is the pathology in the later part. Then only we can intervene properly. Unless and until we understand the pathology, what is the pathology in the phase 1 and what is the phase 2, that will make the things easier. What is important in the earlier part is that we have to prevent more of oxygen. That is the most. Unless and until that sets in the disease, If you prevent that, that will make the things very much easier for the baby later on, I think. That is very important. That is
actually, these are two different things. What Dr. Vikas is telling us is once ROP develops, then at different stages what you are going to do. What we are talking about is what is the incidence of ROP and how does it happen? Whether oxygen is the real culprit or the major culprit, or some other factors are the major culprit. My point is that other factors are the major culprit. Oxygen is a culprit, but is a smaller one. It is a small baby, whereas the big villains are the different ones. And it has been now actually taught all over the developed countries that oxygen is not a culprit anymore. Though in India it is. I agree with Dr. Rajesh that in India it is. But it is not that big a culprit that the court should hang us and say 2 crores for the compensation, because the court is misguided that oxygen is the only culprit. See, and this narrative we have got to change. And only pediatricians and gynecologists can change this narrative.
See, there is a study by Bangar Dogra et al. From PGI, and they say that they have the largest NICU in PGI, and they say that they get only 3-4 babies for laser from their own center. But every day,
that's what I said.
That they have lots of babies coming from outside. They say that it is because of the excellent neonatal care in their institute, which is preventing ROP. Because they are saying that their NICU is such a big NICU, biggest NICU in India. And their own babies are not having ROP. Means their own babies are needing only 4-5 babies are needing lasers. And every day they are getting ROP babies from outside for lasers. There's Subhadra Jalali and et al. They have done one study where they have found that maternal anemia and other maternal factors, maternal nutritional factor plays a big role also.
That's why, madam, we say the third epidemic. Yeah. It is happening only in developing countries, and the bigger babies, on the babies who get compromised neonatal care. If your neonatal care is compromised, you are likely to have more severe ROP.
This is definitely
has come out. The point Dr. Rajesh has already explained that blender is an essential thing. Now 30% oxygen, I don't think we don't have in our hospital also, we don't have 30%.
I don't know, blender is very important.
Most of the hospital don't have this. So
it's simple, sir.
Thank you, Dr. Rajesh.
I have one thing to say. Hello, can you hear me?
Yes, please go ahead.
Definitely, as an ophthalmologist, whatever babies we have seen, if the gynecologist and the neonatologist, they prime the parents. If they have been advised a ROP check, then please insist on getting the ROP check. Otherwise, if the pediatricians and the gynecologists, they don't tell the importance of getting a ROP check, then the parents just don't feel the need of getting a ROP screening.
Yeah, that's correct.
So from your point of view, you have to convince all the parents, if you think that that baby needs to have a screening, then please convince the parents and tell them to get the screening done. Otherwise, they don't feel that ROP screening, because many people come to me, I'll get it next year done or some few months after. So they have to be advised by the neonatologist. This is the most important thing. And then the parents get it done. Otherwise, they don't get it done.
But then,
okay, so with that, I think that was a wonderful discussion.
One more comment, sir. I want to do that.
Please,
if possible, before discharge of the neonatologist should call ophthalmologist for a screening. This should be a practice. Otherwise, if they send, sometimes it happens. This is the factor.
It's so difficult to call an ophthalmologist.
Wherever it is possible, many hospitals have.
No, sir, this is the one of the serious concern. This is the one of the serious concern. What the neonatologist
I think what Rajesh sir has said, we should,
because the screening should be done after 4 weeks of birth.
No, sir.
I think we should proceed forward.
I will intervene because there are many recommendations. There are many societies who are recommending the ROP before discharge. Even if you are discharging at 3 weeks, call ophthalmologist.
Yes.
Because that's why they get primed. It's very important. They get
That's
blind.
it.
This is the most important thing.
Sir, this is the incidence. Baby come after 4 months for ROP screening.
Yeah, it has to be written by
That's why I try to insist on this point.
As the system of NICU matures, I think it will come down.
Neonatologist, if it is written by the neonatologist on the paper, then we are on the safer side, you know. Yeah, the neonatologist is also on the safer side, and the ophthalmologist is also on the safer side. So whenever we screen, we always write on the paper that you have to get it screened, suppose within 2 weeks, 3 weeks, 4 weeks, whatever you feel. But it has to be written on the paper, because sometimes parents come and see when the baby gets a severe ROP, the parents come and tell that you never told us if we don't get the treatment, then the baby will get blind. So you have to tell them the consequences also, then they understand the importance of screening. Otherwise, they just don't understand. They feel that if the baby is saved, everything is saved. No, it's not like that. If you save a blind baby, it's of no use. You have to tell them.
Yeah, that's very true, very true. And ROP is like a jigsaw puzzle actually. 1/3 of the pieces have been put in place by Dr. Shobha Chakraborty, another 1/3 by Dr. Rajesh, and I'm sure many questions will be answered when Dr. Bibbhuti Kashyap finishes with his presentation. And now the baby is delivered. Neonatologist has helped him survive. Now what the ophthalmologist sees and what he has to do, Dr. Bibbhuti Kashyap, please go ahead with your presentation.
Thank you so much, sir. I'll just share my slide.
Yeah, please.
Visible to everybody, and am I audible?
Yeah, both. Very clear.
Let me just minimize my windows. Yeah. So good evening, everybody. I will be talking on retinopathy of prematurity from ophthalmology point of view. This talk has been kept deliberately simple and less of academia and more of practicality. It's a pictorial-based presentation, more of to help the non-ophthalmic practitioners exactly know what we see inside the eye, what we do, what we follow up, and what we see for regression, etc., etc. So the stress and the burden of this disease cannot be overstressed now. As has been already discussed, it's a potentially avoidable cause of irreversible blindness in preterm babies. And as Dr. Rajesh sir has correctly described this diagram of pathogenesis, I'm going to skip this. Basically, this is this is how a human retina looks like. And in non-ophthalmology terms, if I have to explain, this retina gets developed in utero and its development is complete by the time baby is born at term. Now, if a baby is born preterm, the development of this retina gets arrested at different levels depending on how early the baby is getting born. So the image that you see in this presentation is of a retina's posterior pole. That is the posterior most part of the retina, which has the optic disc that you can see here and the macula. This area is the most visually sensitive area of the retina. As we go more peripheral, we say that we are seeing a more anterior part of the retina. So posterior part is more visually sensitive, anterior part is visually less sensitive. Accordingly, it has been divided into zones, zone 1, 2, and 3. So zone 1, roughly, I'm not going to the measurements of it because it is none of your concern. So zone 1 roughly is when the disease is the posterior pole, and zone 3 is when it is the anterior most pole. So zone 1, of course, is a no-brainer, is going to be the roughest, and zone 3 is going to be the modest one.
Easiest.
So what exactly do we see? This is an image of an immature retina. Does this patient have ROP? Let us see. This patient over here has a retinal part which is vascularized, and then there is a peripheral part which is not vascularized. But do we call this an ROP? No, we don't call this an ROP. It is just simply an immature retina because there is no demarcation line at the border. This border is more like an India-Pakistan junction. Most of the problems happen here. So as long as the border is quiet, we are living at peace. So there is no border. there is no vascular tortuosity, it's just a plain simple immature retina. We will just follow this patient up. Problem starts when there is disturbance at the border. So stage 1 is where you get a demarcation line between the formed retina and the unformed retina. And this is because of the culprit called the vascular endogenous growth factor, endothelial growth factor that is liberated from the hypoxic or the ischemic unformed retina. If left untreated, this goes into stage 2 where this line thickens into a ridge. Furthermore progressing, it gives rise to an extraretinal fibrovascular proliferation over the ridge. It raises in dimension 3D. If this is allowed to progress, this goes into a stage 4. All of these images are from my personal collection, so you can stop me freely whenever you want. You can ask the details of these babies as to how I've gone about it. So this is a stage 4A ROP where the arrow shows that the ridge is now trying to pull up the retina. It has tented up this retina over here. It has still not involved the central part of the macula or the posterior pole, the most sensitive part. So vision is still preserved, but it is danger sign. If allowed to progress, this goes to stage 4B where the macula gets lifted up. And here is where you start to lose significant major amount of vision. Allowed to progress, it goes into a complete retinal detachment where the entire retina gets detached up, and this is a very, very grim stage. The entire story and the entire fight, as to say, is to prevent the progression from 1 to 5 by timely treating it, diagnosing it, and doing whatever intervention is required. This is a plus disease, what Rajesh was trying to tell us as to what he used to see. Now, plus disease is where the bad retina starts affecting the healthy retina and it starts throwing the vessels into tortuosity. Now, when this happens, this means that the disease is going to progress and you need to treat. Plus means treatment. Something called as a pre-plus disease where the tortuosity has just started but not reached the significant enough level to call it a plus disease. So this again is a borderline zone, depends on surgeons or the treatment person's discretion whether or not to laser it. Now this, as sir has already discussed, aggressive posterior ROP, this is an ocular emergency. Now, why is it a problem? The problem is when you are not an ROP expert, or you have not been screening ROP on a regular basis, you may see this and may as well call this a normal retina with just normal vessels. But these are extensively tortuous vessels with enclosed vascular loops over here. Now, to naked eye, these have vasculatures, but if you do the angiography of these patients, what you will see is that these areas actually which seem vascularized are actually not perfused. So if you treat these babies, you may end up under-treating them, only lasering the peripheral vascular, non-vascular areas and leaving these areas thinking that these are already vascularized, but in reality, they are not vascularized. So these lead to treatment failures and progression of an already existing emergency. And that is where aggressive posterior ROP is tricky. And this has a very aggressive course, and sir has rightly said, it progresses within days. So coming back to the burning question of past half hour, when to screen, multiple guidelines by multiple societies and कार्यक्रम. So going ahead one by one, RBSK suggests less than 34 weeks or less than 2000 grams. First screening at 4 weeks or within 32 weeks of postmenstrual age in infants more than 28 weeks, or 2 to 3 weeks in infants less than 28 weeks or less than 1200 grams, as sir has discussed it. NNF loosens the noose a bit and reduces the weight guidelines to 1750, which is drastically different from the American Academy guidelines, which are very liberal. So the question is when to examine, how to examine, when to screen. In my personal private practice, I have advised whichever pediatricians we are associated with to advise the babies a preterm and ROP screening, even if the babies are 36 weeks. Baby is less than 37 weeks old, go for ROP, because as has been discussed before, you will see ROP even in 2000 gram babies who are 34, 35 weeks old. The level may be liberal or it may not be an AP ROP, but ROP might still be there. So we don't follow these guidelines strictly. We are tighter than these guidelines, and we follow a screening protocol of all the babies who are 36 weeks or less. We can screen the babies at NICUs, PHDUs, or OPDs. What we basically need is, to your left, a pediatric tropicazole plus or tropicamide phenylephrine concentration, which is half dose of used for adults. And these small instruments that you can see over here, this is the wired speculum, an indenter, and a condenser. What should be the screening interval? For a rough understanding of the intervals, just remember, if it's a zone 1, it's 1 weekly screening. It's zone 2, 2 weekly screening. Zone 3, 3 weekly screening. And if it's a plus or a pre-plus, every half week. Termination is usually done at the completion of the treatment, or if the retina is completely vascularized. Now, telemedicine has a big role, potential big role to play in telemedicine, in ROP, because there are places where ROP experts cannot. So for those areas, do I have to stop?
No, please. I request once again all the panelists, please mute yourself. Only the speaker will be unmuted.
So
kindly
till
mute
the time,
yourself.
if ROP experts are not available, RedCams and Trinetra fundus cameras can be used for telemedicine, where you can snap the fundus images and you can send it to the concerned ophthalmologist. Now, how do we manage these babies? 3 options: laser, injections, or surgery. Now, what are the guidelines on treatment? So we have to treat the type 1 ROPs. Now, what are they? Type 1 ROPs is any ROP in zone 1 with plus, or any zone 1 disease with stage 3, with or without plus. If it's a zone 2 or zone 3 disease, it has to be a stage 2 to 3 with plus. That is, you have to have a ridge at least with tortuous vessels to call it treatable. Other than the ones I have mentioned, can be observed weekly or 2 weekly, depending on the zone and the intensity of or the onset of a pre-plus. So how do we treat? The gold standard of treatment for ROP is laser. So what does laser do? As I have already said, there is hypoxic retina that releases VEGF. So you either treat it by injections, or what laser does is it destroys that retina completely. So converting the ischemic hypoxic retina to an anoxic retina. And once the VEGF load reduces because of this, ROP starts to regress. Methods are pretty straightforward. You can do it anywhere, whether it be PhDU, NICU, or wherever. Just that you need to have a backup of anesthetist and neonatologist and a monitoring and resuscitation facility available. The medications and instruments used are fairly similar, except this machine is a portable laser that we have to carry if we are doing these lasers in NICUs or PhDUs. This is a post-laser follow-up depends on the type of ROP, the zone of ROP, and the extent of laser done. Sharing some of my regression photos, you can see on the left, there is a case of stage 3 ROP of zone 2 anterior with a plus disease. After laser to your right, we can see this ridge that was there in the eye has collapsed, the tortuosity has resolved, and the retina is stable. And this baby is going to gain good vision with limited restriction of visual field. The outcomes are usually straightforward and great with babies gaining more than 6 in most of the cases. Long-term follow-up is of course required to address other ocular comorbidities till at least 5 years of age. Now, coming to the burning topic of this day, as regarding ROP management, anti-VEGF therapy, it's a relatively novel indication. It's a miracle rescue. Why? It's because when there is an aggressive posterior ROP of zone 1, and if we intend to laser everything, we cause a restriction of the field. And vis-a-vis laser in AP-ROP, it's a very, relatively smaller duration of procedure, easier on the pediatrician, easier on the ophthalmologist. But what is the major advantage of anti-VEGF therapy in ROP, AP-ROP over laser? I can explain to you with this picture. You can see on your top left, there is a patient of AP-ROP which has been lasered, and you can see the extent of laser. It is almost extending inside the macula. Now, what we are able to preserve is very less amount of visual field. Now, seeing a similar baby in image C, what we have done in this patient is we have injected the anti-VEGF. So what it has allowed is it has allowed for growth of blood vessels on the avascular area. So what we are left is a very small residual avascular area over here, which if lasered will not cause that amount of visual field loss as would have caused in this eye. So we are able to save visual field with anti-VEGFs. The commercially available anti-VEGFs are bevacizumab, ranibizumab, aflibercept, or pegaftinib. A procedure again is very straightforward, need a written informed consent. Consent is very important because we have to choose between bevacizumab and ranibizumab. It's a lot of controversy over there. Done in OT settings, preferably under strict asepsis, and injection is given under microscope visualization with a backup of anesthetist and neonatologist. Regarding the dosing, there is no clear-cut consensus on the dosing. Let me tell you this. And currently, multiple trials on anti-VEGFs are going on. But in our setup, we give a 0.625 mg of bevacizumab or a 0.25 mg of ranibizumab. There is a video of injection. Note the coming right about now. 1.5 mm from the window. It's a very straightforward procedure. This is how much time it takes. Now, see the result of these injections. To your left, you have an AP-ROP with so many convolutions. After injection, see the vessel straightening out and extending. An extent of vascularization has increased from a zone 1 to a zone 2 mid. So now if we laser over here, if you would have laser, we would have laser till here. But in this case, a laser over here would suffice. So we have saved this much of retina for visualization and the field. One of my other cases that I have treated, both eyes AP-ROP, injection given, vessels straightened out dramatically, but it has a problem of recurrence. It recurred with ridge formation over here. So I had to laser the baby's eye, and this is the 6-month follow-up picture of that baby, and the baby is doing pretty fine. So yes, injections do fail and recurrence do happen with these injections. They don't come without concerns. The effect of anti-VEGF on developing organs, we don't know. The number of injections required, no clear-cut consensus. Efficacy, safety, still to be determined. Systemic absorption, not sure. Off-label use, on-label use, multiple issues with these injections. Coming to surgery, surgery is the last hope of stage 4 and stage 5 ROP. These should be done at the earliest. In stage 4 ROP, since the macula is not involved, the prognosis is relatively better. But in stage 5, because the retina is all crumpled up and closed, it is just a globe salvaging procedure and any kind of navigable vision. So the counseling in surgical patients is a must, and the patient should have a realistic, expectation with the outcome of the surgery. This is a baby who had both eyes in 5 hours. Showing the video of one of the eyes right behind it. Usually these patients, the lens packs has to be sacrificed, and then it is another plethora of issues. I was lucky enough to manage this now sacrificing the lens. I get to the figures. Special mention to our has enabled high risk has allowed me to express myself very, very good. These are my results for the stage 4 ROP, where you can see in your left there is a traction band which is just about to elevate the macula, but with surgery we have cut this band, and left is the 6-month post-op picture. This surgery I had performed at RP center. These are my RP center data, and this retina was perfectly fine. The baby is doing fine. Stage 5, it was a closed open funnel type of RD, open closed funnel type of RD. I had to excise the lens and excise the funnel and try to open up the retina with retinectomy. I was able to eventually settle the retina, but we can see over here the retina's health does not look good. It's a very pale looking, sick looking retina, and it doesn't give you much vision, but that is the only way to treat stage 5. So surgical outcome are poorer for stage 5, of course, but surgery is possible because sometimes the attached posterior pole has underlying viable retina beneath the apparently closed posterior funnels. Surgery is the last ray of hope. However, prevention is better than cure. The take-home message, as again Dr. Rajesh said very, very rightly, that we have only 30 days from the birth of a preterm baby to diagnose, evaluate, treat, and manage to save the baby's eyes from a potentially irreversible, though treatable cause of blindness. So these then Roshni ke 30 days to vision. Thank you so much for your patient hearing.
Nice presentation.
Wonderful presentation, Dr. Bibhuti.
Beautiful.
Beautiful presentation. I'll give you a scenario. I think that will clarify most of the things. You have a baby of 1500 grams. There are 4 scenarios. In one, baby is born at 28 weeks.
Yes.
In second, 30 weeks, 32 weeks, and 34 weeks. When would you like to call them for? When would you like to see them? I think that will clarify most of the confusions that we have here.
Yeah, I know. There are multiple guidelines for multiple things. But if the baby, I take 30 weeks as the cutoff. If the baby is less than 30 weeks, going by the American Academy of Pediatrics, for a stricter control I'm talking about. If the baby is less than 30 weeks, examine within 15 days. That's my protocol. If the baby is more than 30 weeks, you may wait for up to 3 weeks, but never ever delay the baby more than 4 weeks, more than 28 days. So in any which ways, you have to examine the baby within a month. Any baby who is less than 36 weeks, you have to send the patient for the baby for examination. Any baby less than 36 weeks, examine within 30 days. Yes, if the baby is less than 30, that gets into extreme prematurity, then 15 days is my cutoff.
Dr. Rajesh, is there? Your comments, please.
So we have to go by the guidelines given by the government. RBSK guideline, even the ROP task force guideline by the Ministry of Government of India, Ministry of Health. They have a strict guideline: less than 34 weeks, all babies screened; less than 2 kg, all baby; and 34 to 36 weeks with risk factors of the screen. And time of screening, 4 weeks, all the babies except babies who are less than 28 weeks or less than 1200 grams if gestational age is not sure. Practically, we take all babies less than 1200. By day 15 should be third week, basically. Third week, we should be screening period for all these babies. And other babies, even the babies 32 weeks, say 1.3 kg, very aggressive course, very bad course, very ventilation, sepsis, shock, this, that, very aggressive neonatal period, then I would like to get a screened in 3rd week. This baby also, because this baby also has got some chance of developing APROP. So sickness of the baby also matters.
Dr. Bibhuti.
May I ask a question to Dr. Rajesh and Dr. Bibhuti both? What are the systemic factors of the baby we should look for, and what are the systemic factors has to be corrected for the baby? Is there any guideline for that?
That's what he had answered. I asked this question. He told that you will see the hemoglobin count, then sepsis, 3 things. Dr. Rajesh, am I right?
Apnea, yeah.
Apnea, sepsis,
septicemia and anemia.
Septicemia, anemia, and other things. This question is already answered.
Thank you.
Dr. Bibhuti
was asking.
Yeah. About the use of anti-VEGFs, is there any preference of a particular type of anti-VEGF you'd like to use in these babies?
Yes, sir. Now, I really wanted that someone picks up this question and asks. So there are 2 trials that have been used to quote and unquote the use. Although a lot of neonatology forum guidelines, although coming in this year, they are not updated correctly. Now, there are 2 widely used drugs, bevacizumab and ranibizumab. What is the issue? Bevacizumab has been approved for injections. Bevacizumab has been approved as effective with in BEAT ROP study. But problem is that the companies manufacturing bevacizumab have not applied for a patent or have not applied for a clearance for ocular use. Now, if anything goes wrong inside the eye, the drug company will not come and save you, because they will wash off their hands saying it is not meant for ocular use. Now, ranibizumab till last year was not FDA approved for use in ROP, but it is only last year that Rainbow trial studies, which I was also a part of as a senior resident in RP Center. Rainbow trial studies have come out and they have already applied, and it has already been cleared for injections in ROP babies. PGI Chandigarh and AIMS have literally stopped using bevacizumab for fear of such medical legal cases, but they can stop it because patients, there are no extra charges to the patients when they get admitted there. We have to look at the socioeconomic platforms these patients come from, because they are having ROP. One of the causes is socioeconomic platforms. So we have to explain the baby's parents properly about why bevacizumab is a bit iffy. But can we give it? I mean, why not? Everybody is giving it right, left, and center. You can always give bevacizumab, but yes, with proper consenting. If you talk about technicality and legality, strict technicality, then yes, bevacizumab, although approved for use, the drug bevacizumab and the company manufacturing bevacizumab has not applied for clearance to ocular use. So that makes it a bit tricky. Now, regarding the efficacy of bevacizumab and ranibizumab, bevacizumab is actually more effective than ranibizumab because it is longer acting and it has lesser chances of recurrence. In Rainbow study, there are higher chances of recurrence with ranibizumab than what was seen with bevacizumab. So is effectivity there better with bevacizumab? Yes. Is it cheaper for the patient? Yes. Does it have, does it have any other problem apart from the patenting? Probably not if you have proper aseptic environment. But have they applied for an ocular use patent? No. Why? We must ask the companies. Will there be of any use to poor patients if you apply? Why not? So that is a tricky situation over. So my choice in my patients is usually bevacizumab, given the fact that I have taken consent and explained the patients all these issues in their own simplified terms.
Okay.
And also, I will comment. By guideline, our National Neonatology Forum guideline, which came this year only after extensive deliberation, they have clearly written only bevacizumab should be used in neonates for ROP.
Sir, I would like to differ over there. in a way that regarding those guidelines, I have actually referred to the who's who of ROP in RP Senator Dr. Parijat Chandra, and he will be shortly looking into it, because it does not stand valid as of now, because the only drug actually approved for ROP is ranibizumab. Although we should give bevacizumab, I don't understand why the company is not applying for the ocular patent use. But stating this on legality basis, ki no, bevacizumab should only be used, that is a bit wrong statement. And this is also followed in PGI Chandigarh, by the way. They have stopped using bevacizumab and started using only ranibizumab now.
But the official guideline for our society is like that only, and head of this guideline is head of the PGI.
This guideline, this should be there, provided the bevacizumab gets a patent for ocular use. But sir, अभी ocular use का patent नहीं आया, तो हम लोगों को off-label consent लेकर करना पड़ता है. क्या ज़्यादा better है bevacizumab? Of course, better है bevacizumab. But company patent ले ही नहीं रही है. क्यों नहीं ले रही है? पता नहीं. But yes, any given day, bevacizumab is better, it's cheaper, and if the patients agree to sign the consent form, that is the drug we should be using if you can take care of the asepsis.
Sir, your experience, sir, one question, sir. So your experience with RET scan. Now, getting an ophthalmologist who are very good to detect this ROP is very difficult in many of the cities. What is your experience with RET scan?
So RET cam basically is use of RET cam as telemedicine is a bit controversial. Why? Because at the end of the day, retinopathy of prematurity, the examination, you cannot replace it with a fundus picture. I mean, if you have no option, you have to use a RET cam or you have to use a trinetra. But nothing beats a direct fundus evaluation, because you may miss peripheries, you may miss subtle signs. The baby may be going into pre-plus. You may have media haze which precludes the capturing of the image and all of that. Plus, RET cam is extremely expensive. So the cheaper version of it, the Indian version, the Trinetra version, is being used everywhere, and that should be the norm. It must be used. But if you're asking me, is it a replacement to direct clinical examination? Absolutely not.
Just adding to that, the basic difference is between a 2D image and a 3D visualization of the structure. So that gives a definite edge to the actual examination of the retina.
So many other places, both Dr. Bibhuti Bhushan and Bibbhuti Kashyap is not there. So what they can do?
Sir, even looking at the periphery is sometimes tough through the RET cam.
You have a very good ROP expert in your city, Jamshedpur. That is Dr. Bibhuti Bhushan. And I think in each city, there is one at least ROP person, because in India, there are 100, 200, I think, ROP experts. I have a question to Bibbhuti Kashyap. Like when we do laser, you have very beautifully shown that some of the cases where with injection, you have saved the peripheral vision also. But then when you do laser, and the regression is there, the patient never comes back. Usually the patient does not come back with reactivation. But when you combine anti-VEGF and laser, then the patient sometimes comes with a late reactivation. So if the laser is done and ROP is regressed, you don't ask the patient to come for a follow up with the ROP regressed. But if there is a combined treatment, till how long you will call the patient for follow up? What is your protocol for follow up?
Recurrence with anti-VEGFs is a known phenomena. That is what I have been laying stress on. And that is why I say Dr. Rajesh sir's statement about the National Neonatology Forum guidelines makes absolute sense. Sir is right, because this recurrence is a huge problem with ranibizumab. They come for 26,000-28,000 rupees and they have a very high rate of recurrence. So the patient ends up paying, patient is dissatisfied. Recurrence is less with bevacizumab. So if you're using ranibizumab, you have to have a longer follow-up of the patients. So if I'm injecting here or at AIMS, if we used to inject ranibizumab, we come back in we follow the babies up till 60 weeks post-menstrual.
And if you give bevacizumab, then?
No, bevacizumab also mostly follow-up is required till 45 weeks or 50 weeks and the vascularization is complete. And even if it is not, the retina stays relatively stable for a longer period of time. So the safety issue vis-a-vis recurrence is better with bevacizumab. But if you ask me follow-ups, 60 weeks is what my target is. They have to have a tension-free 60 weeks.
Okay, suppose the patient has regressed with laser. So you are absolutely sure that in 100% cases there will be no recurrence in stage 3 ROP where you have done a laser and it has regressed. You will not call the patient for follow-ups.
That is absolutely wrong. No.
That's what I'm saying. In what situation there is a recurrence even after laser? Are there any situation?
I'll just show it to you with the use of an image from my presentation, which I had hidden because it will get too technical and too ophthalmology. So the other people will get bored. But now that you have asked, I'm going to show it. It may be of use to our ophthalmologists. Wait a second.
Because we have a JHOS panelist also with us.
I'm just doing it. Wait.
I have a question, sir. In which treatment more risky, in ROP, injectable or laser? Hello, sir.
You are audible. He is explaining to me. Then
Okay.
Come to you.
In which treatment more risky, in ROP?
Just a second.
Injectable or in laser?
I'm not audible. You're not audible, sir.
In which treatment more risky, sir? In ROP, laser or
Sir, can you please, sir, समझ नहीं आ रहा सर.
कौन सा ट्रीटमेंट ज्यादा रिस्की है, लेजर करना या फिर इंजेक्शन देना?
Injection,
Laser is any day safe, but what price are you paying for safety in a patient of AP-ROP? You are giving them the baby a tubular vision. So in AP-ROP babies, and any which ways, injections you only give in zone 1 or at max zone 2 posterior. You don't give in anterior ROPs. So if you have a zone 1 AP-ROP, you laser, the baby will be safe. But what vision will he be having? A tubular vision. You give injection, you expand the visual field a bit, and then you can always laser. So recurrence-wise with respect to safety, safety with respect to recurrence, lasers are better. But with respect to outcome, anti-VEGFs always give superior results when you combine them with laser.
Cost-effective, sir.
And my question remains unanswered.
Yeah, I'll just do that.
Yeah.
So this is an example. To your left is a patient of is a premature infant. Now you can see tortuosity and vessels. Most of the non-ROP experts who are not usually used to screening, and treatment, they will laser somewhere till anterior to these vessels. But if you do the FFA in these AP-ROP babies, you see these CNP areas corresponding to these vessels. These loops are avascular. So you will end up lasering only till here, wherein you should have been lasering till here, irrespective of these vascularities. That is one cause of failure. Other cause of failure is when you do not laser correctly and you have skip areas in laser. Therein, the progression, the ROP progresses despite you lasering them. So in such cases, when the ROP progresses despite laser, what is wrong with this? Just a moment. Yeah, so in this image, the retina just anterior to the ridge was not lasered, and the laser was in more posterior, more anteriorly. So this unlasered area led to increase in the ridge thickness, increase in the elevation, and started causing focal detachment around the ridge. So the treatment in these cases is to barrage this ridge posterior to the, barrage the retina posterior to the ridge, so that it causes a border of attachment beyond which, even if the traction is there, it will not progress to macula. So to answer your question, inadequate laser and inadequate extent of the non-vascular, non-perfused area is one of the main causes of failure after laser. So yes, lasers also fail.
So we have to be very careful while we are doing laser, because we have not covered it nicely, and full laser is not done, and CNP areas, capillary non-perfusion areas are left.
Oh yes,
it will recur.
Yes. I mean, these lasers are pretty different from the lasers that we do for diabetic retinopathy. There, you have to have spacing in the burns. In ROP babies, you have to have near confluent burns. You just burn that area, because any area you leave is a potential source of VEGF. It's going to cause recurrence or failure.
So one more question, like in stage 4A ROP, if the patient is diagnosed really on surgical intervention is on time, stage 4A ROP, when the macula, there is no traction and nothing. So that time vision is quite good. So is there any, any situation when in 4A ROP also vision can be, prognosis is bad?
Yes, I respectfully disagree to whatever statements people make about their overconfident and over elaborative results of stage
4A ROP.
No, absolutely. I beg to differ, because once you have ROP, you have other coexisting ocular morbidities as well. You may have cataract, you may have complicated cataract, you may have amblyopia, you may have strabismus, you may have exotropia, because of which you may have strabismic amblyopia. Your optic nerve may be hypoplastic. Your macula may be hypoplastic, even though developed it may be hypoplastic. So your potential may be less. So when you talk about, what you have to talk about is the anatomic success and the functional success.
Right.
Is anatomical success very, very good in stage 4? Absolutely. There's no two doubts about it. But can anatomic success corroborate with functional success? Hell no. So in stage 5, even anatomical success is a very rare thing. In stage 4, anatomical success is a given more often than not. But does that anatomical success corroborate with functional? No.
And in sometimes we have another findings also. Let me say in the lens that there is a abnormality in the macula disc. So factors are there. So
just one thing I want Dr. Bibbhuti Kashyap to just emphasize. That we know that many of the babies who have ROP, they regress spontaneously. Some of them need treatment, and after treatment they regress. But still those eyes are not absolutely normal. They still have some sequelae.
Yes.
Some of them develop myopia and other things. Just kindly throw some light on that. The sequelae of ROP that we can get in a regressed ROP.
Yeah, sir, in ROP, a lot of things can happen, as I said. You may have optic nerve, which is hypoplastic. You may have optic nerve partial atrophy due to the extensive laser we have done all around the retina. We may have macular hypoplasia or macular atrophy. We may have exotropia due to the drag. Even if we laser the elevation, or even if we surgically manage, there is some amount of residual drag on the macula, which, may not compromise the anatomical outcome, but the striae caused by the drag, it will cause macular distortion and some amount of distortion of vision. We are going to operate the baby whenever we have to operate, but the scientists like Huber and Wiesel said on the experiment with monkeys for which they got Nobel Prize, deprivation of as small as 1 week duration can cause amblyopia and shutting off the vision centers. 1 week duration. If we extrapolate that finding to humans, do you think you will operate the babies? I mean, do we operate babies within 7 days? No, because the detachments don't develop before 7 days. But vision is compromised. So even if we operate, we have already passed that bracket of 7 days. So we will any which ways have some amount of amblyopia. We may have complicated cataracts because of laser, because of surgery, because of the disease. We may have evidence of high myopia. So all of these things, nystagmus can develop. So all of these things will lead to a subnormal visual outcome in babies. But yes, there are babies who after stage 4 luckily get a 6/9 or a 6/12 vision. Those are the babies where stage 4 is extremely peripheral. And I would like to question those surgeons whosoever operate on stage 4 ROPs. If you are getting such good visions with 6/9, you might as well just laser barrage it posteriorly, just like I showed, and you may not even need to do surgeries in those babies. If you're getting a 6-9 with surgery, you might as well have done without the surgery.
They might get stabilized without surgery.
Yeah, without surgery, with the posterior barrage, you may not have needed to enter the eye. You may have actually spoiled the process of the eye by entering the eye and inducing an increased rate of cataract formation.
Okay.
One more thing, ma'am. Just I want to add in Dr. Bibbhuti Kashyap comment.
Yes, sir.
That there is a chance of developing amblyopia, nystagmus, and all ocular morbidity. So even after treatment or say management of the ROP, we must have focus on the rehabilitation part also. As soon as the treatment is completed, the child should go to it's a rehabilitation. Child requires visual stimulation therapies and all the things. So that is called physiotherapy part. So these part of the treatment should also be included in the management. Otherwise, we will not able to get the functional aspects of the treatment. So the rehabilitation is the important aspect of ROP management.
Exactly my point. I mean, restoring the anatomy is a surgeon's perspective, but restoring the function is sir's perspective. I mean, we have to refer it to a pediatric ophthalmologist and take care that the amblyopia part of it is being taken care properly.
Right. So we need to refer it to the pediatric ophthalmologist after all these surgeries and everything.
Absolutely.
One thing, Dr. Bibhuti.
Yes, sir.
Yeah, if a comprehensive ophthalmologist who has access to indirect ophthalmoscopy does a ROP screening, what can be the medical legal issues in that case?
Sir, can you come again with the question? I didn't get you.
If a comprehensive ophthalmologist who has access to indirect ophthalmoscopy,
yes,
he or she is doing routine indirect ophthalmoscopy in his cases, does a ROP screening. So what can be the medical legal issues in that case?
Sir, medical legal issues will be there as long as the comprehensive ophthalmologist is experienced enough to regularly screen those babies. Medical legal issues can be pretty big, especially is the case when you are not able to diagnose a pre-plus disease from a normal disease. In a pre-plus case, you have to follow up every 4 days, 5 days. If you say that judgment is important, if it is a pre-plus or if it's a normal tortuosity. So people get confused between normal tortuosity of vessel versus a pre-plus form. A gross form of plus is also sometimes missed. So basically what people are used to looking is at the ridge, the line, the elevation. But the tortuosity part often plays a very big role. Even in case of AP-ROP, I have had patients who have been misdiagnosed as normal immature retina and has been asked to follow up. The baby basically, which I showed the surgery of, this baby was he was a baby of AP-ROP. This baby was diagnosed as no ROP and just immature retina. And this baby progressed to AP-ROP and full detachment, as you saw in the picture. So, that is where the catch is. We have to differentiation between AP-ROP and immature retina and differentiation between pre-plus and normal retina. That is
question.
The person needs to be properly trained, and that will come only when you are into screening these patients for a long time. If you are, there's not a problem. But if you don't, this can have huge medical legal implications.
So can we diagnose pre-plus and plus with RETCAM?
Yes, ma'am, we can. We can diagnose it with RETCAM also. We can diagnose it with Trinetra camera also. But if you ask me, what is the accuracy of diagnosis of a Trinetra camera and an optometrist who is doing a Trinetra, and you have just taught him, oh, this is what ROP looks like, versus an ROP expert who is doing it, it makes a hell of a difference. So yes, RETCAM or Trinetra is an answer where you don't have experts and you have to screen. But it is not a replacement, or it is not superior to a direct visualization, indentation, and examination of an ROP.
Okay, you mean to say that sometimes we may skip these lesions if we are very trained and we are doing RETCAM and other things, because see, everywhere we don't find ROP experts, but sometimes we can be caught in a medico-legal problem if we don't have such facilities and we are doing red cam ourselves, means I mean ophthalmologist, like Dr. Sujoy pointed out. So, so we are doing ourselves, like in his place. He has premature babies, and if he does not find any ROP expert, if he does start himself, so he may he may skip. That's what we are asking.
Yeah, I'm saying that may be skipped. So
it is all about experience actually. If the person has seen or is experienced enough to find out those things. Doing indirect ophthalmoscopy is a routine part of examination. It's not
Dr.
a
Bibhuti,
very...
connect, Dr. Bibhuti. Dr. Bibhuti.
Yeah. Yes, sir.
Yeah,
Yes, sir,
I have been practicing retina since 1984. The only thing that troubles me is the ROP. Because the child comes crying, will you examine the child is crying? You can't examine the patient, you can't open the eye, the kid squeezes the eye, and no amount of local anesthesia or vocal anesthesia or total anesthesia, wo to chilata itna hai, it's very difficult to see the patient. And hats off to ROP people who do it. I can't do it.
My husband is such a senior retina surgeon.
रोता है तो मेरी जान निकलती.
वो बच्चा इतना रोने लगता है कि सब हम भूल जाते हैं.
But to tell you the truth, during examination, if the baby keeps on crying, we are happy that at least the baby is not going into apnea. Baby is not going into apnea. The baby is healthy.
I don't like crying people. Oh my God.
But we have lot of problem.
और आँख दबा देता है, और squeeze करता है. Oh my God, this is tough.
So crying baby is very difficult to examine.
No, I mean, if the baby is that uncooperative, and if you have an NICU or a PhD setup, sir, I mean,
excuse me. You said baby that uncooperative. Who will the baby so cooperative? What do you mean by uncooperative?
नहीं मतलब कुछ babies होते हैं, who are sedated. But my point is that if you are having such trouble, you can always use fentanyl infusion for sedation, controlled fentanyl infusion for sedation to sedate the baby, and you can progress. This especially is the problem with lasers of zone 2 posterior and zone 1 APROPs, which are non-responsive to anti-VEGFs. You have to laser them for a longer time, small pupils, non-dilating, non-responsive. Those patients, I mean, yes, a fentanyl infusion can be used, but a zone 3 ROP, I mean, you can do it in 20 minutes time. So you may not use that infusion, but that, to answer your question, that and plus a pacifier will do the job for you.
Hats off to the ROP people, yeah. Hats off.
There is one question that has Dr. Amit Wasli has messaged. How many rows of laser barrage usually suffice in ROP 4A if you have a fair experience? The second part is, in what cases should we laser in between the blood vessels posterior to the ridge? Have done a lot of ROP children, but never done it posterior to ridge. This is Dr. Amit Wasli.
Yeah.
From where?
Yeah, so to answer Dr. Wasli's question, when you are lasering posterior to the ridge, you have to judge on the extent. Sometimes the detachment is so much that it is just nearly abutting the macula. So judge if you are better off by lasering the retina, or you may be compromising the field very much if you're lasering posterior to the ridge and the detachment. If you are very much away, then you may as well give at least 4 burns, and that should take care of the ridge and it should prevent it from progressing. If it is too close to the macula, with respect to the elevation the ridge has caused, then you are better off going ahead with the surgery. In between you don't have to laser in between. I mean, it is a confluent burn. You don't have to laser in between the vessels or not over it has to be a continuous row over just behind the ridge to just secure the ridge and have a collateral adhesion. Similar to what you do anterior to the ridge. There is no difference. Just that 3 to 4 burns, just make sure that you are behind the detached part and you are well away from the macula, taking care that by giving 3 to 4 burns or 5 burns, you are not compromising the visual field too much. That's all. There's no clear-cut consensus as to how many laser rows you have to give. you may as well give 4 rows. I mean, I usually practice with 4 rows.
Thank you. I think ROP is a very, very interesting and very evolving subject. We cannot cover it in a couple of presentations and in a couple of hours. I think Dr. Bharti should take it forward from here. The discussion.
Can I ask a question? Dr.
Yes.
Bibhuti.
Yes, Dr. Bajoria.
Yeah, please.
See, no, I've been wondering, we have all been talking about anti-VEGFs and other treatment. There might be people who can't afford anti-VEGF.
Absolutely.
So what do you do for such people?
No, sir. Not some. A lot of them cannot afford anti-VEGFs. That is why the first thing is to force the drug agencies and drug companies to legalize bevacizumab as, fit for ocular use. Once that is done, it will solve a lot of problems, because when I treat my patients, most of them are bevacizumab patients, and that's pretty cheap and they're doing pretty fine. So that is one thing. But if the patients cannot afford even that, the only way is laser. Then you have to compromise with the visual field, but perform an extensive laser, and that should do the job for you. Although it will end up in a tubular vision, but that's the best that you can do.
Thank you, Dr. Bibhuti. Thanks.
Okay, so now the vote of thanks will be done by Dr. Bibhuti Bhushan. But then before that, we want to show a virtual award,
felicitation.
And it's a lot of fun after such a hectic and long discussion. So previously also we designed this and it was very appreciated in the ophthalmology group. I hope the IAP chapter and Fuxi chapter will also enjoy after such a long discussion. So this is a felicitation virtual ceremony. So after that, Bibhuti Bhushan will do the vote of thanks part. We will share this.
Yeah, please share.
We will share this in the group also.
Okay.
Bibhuti Bhushan?
Yes.
आवाज आ रही है?
Yeah, आवाज आ रही है.
Thank you so much. I hope you liked it. It's more of a fun.
Yes, it was very innovative.
Very nice.
Ma'am, देखिए अपना.
Yeah, Doctor. We were blessed to have Dr. Shobha ma'am throughout the program. Actually, hats off hats off to her enthusiasm. And
we will send the certificate and the memento also to Dr. Rajesh's place and Madam's place. And now
it was an excellent experience.
The very important home take message is all responsibilities goes to the obstetrician part. So they have to remain very alert and very maintain the documents for preventing or avoiding the future medical legal responsibility.
And
by hearing the whole of this discussion, the conclusion is that obstetrician has to work hard and more efficiently to reduce the premature deliveries so that the burden of the pediatrician and ophthalmologist reduces.
And Madam,
So
this is the first time the obstetricians have joined, because long back we did one ROP workshop, and that time Rani Children Hospital only we took Dr. Parijat Chandra, and he came from RP Center AIMS with the pediatricians, the neonatologist. Never there was a pediatrician, ophthalmologist and obstetrician.
There was. We had in Ranchi.
No, but the last time, no, it was only
the patient. Besides treating the premature labor or preterm labor, with all her ability, they should explain all the complications which may occur in this preterm baby in spite of all efforts of neonatologists, gynecologists, and pediatricians. And it should be recorded in written information.
With the evolving facilities and with the evolving treatment modalities, I think things will be changing very fast, and we must have this kind of a webinar or seminar every couple of years. Needed to update ourselves.
After 1 year, we again come up with the similar ROP webinar, because it was quite a fun as well as education also.
And you must include obstetricians.
Yes, ma'am.
That's what I'm saying, ma'am.
This was a wonderful experience for all of us. I'm sure everybody has benefited from this webinar. My sincere thanks to Shobha Madam. We were really privileged to have you here on this webinar and listen to you after, say, about around 30 years. It was a very nostalgic moment for all of us. All of us have been, most of us have been your students, ma'am. So it was really very kind of you to accept our invitation and give such a wonderful presentation. We are really privileged and obliged to your knowledge and everything, ma'am. Thank you very much, ma'am.
Thank you. And I want to congratulate to Dr. Bharti ma'am and her team, who made the beautiful platform in which the noted pediatrician, ophthalmologist, and gynecologist in one stage. Thank you, ma'am.
Finally,
Dr.
a big
Rajesh.
round of applause for Dr. Bharti Kashyap.
That we'll do first. Let us acknowledge the speakers. I think Dr. Rajesh, it was a wonderful presentation. You answered a lot of questions, lot of confusions were cleared, and it was one of the most enlightening presentation, very lucid, very authoritative, and very informative. We would like to hear you more because there are a number of other scenarios also where ophthalmology and neonatology, it crosses lines. So thank you very much for accepting the invitation and doing the honors in this webinar. And Dr. Bibbhuti Kashyap, it's really always a pleasure to listen to you. You are so clear in your mind. The presentation is absolutely crisp. Your videos are very good. And everything is good because you have done your work. You have done the hard work. And we look forward to your contribution in the field of ophthalmology in Jharkhand and beyond the limits of Jharkhand also. So thank you very much for your presentation. And I'm sure ROP has gained momentum from this webinar. So now all of us have to really study, know about, try to find out what ROP is all about, how we can improve the patient care, how we can save the vision of the child. And that was the purpose of this webinar. And I think all the panelists from the gynecology, ops and gynae, and from the pediatrics department also, they have also. And,
and in the last, we should thank the pharma microvision for
and Mr. providing us this platform.
Yes, providing us this platform because previously it was designed on the 16th of August, but because of some problem.
On a very short notice, actually,
Yes,
they came
yes,
forward and they
yes.
did this. They did a
So
wonderful
thank
job.
you, Micro.